Good morning, everybody. So this is always a bittersweet moment. I see lots of new faces here. We have the craziest last week I have my welcome meeting with all the new interns next week. So we'll have a little bit more individual time. But I want to say that change is always, I'm a big advocate for change, because I think that's how you renew yourself and how you think about being part of the future. This is an unusual year because we actually have our reunion weekend, our first ever reunion weekend, and we're excited about that. And part of that is really about sparking innovation and healthcare value, as you know. And that is really about trying to think about change in our profession. For those of you who haven't started, to make sure that it is the kind of profession so that, Jeff, I don't know if you remember this, so you can become the doctor of your dreams. This is, of course, Jeff and I were doing with Rachel Lemon at one point. But I think this is really right. It's about what is it, why is it that you guys went into medicine? What is it that you'd like to achieve? What are those tools and opportunities that you'd like to have at your fingertips to be able to make those kind of changes and make these impact on people's lives that you would like? And what is your role going to be in making that process happen? I'm excited to see all the final presentations. Gotten a sneak peek before. The people who are watching, all the new folks, will be amazed by the polish and the way people have been able to present themselves after their time in this program.
So I worked with the iSpy office on a variety of different things. Worked with the PMO, worked with Dr. Meliska on quality of life, Dr. Chen on low risk. Worked on Surmount, but then luckily Rebecca introduced me to the symptom management service, and it became something I really enjoyed. And so I decided to create extra work for myself and present on the California aid in dying law that just got passed in November and then went into effect June 9th. So really recent, a lot of controversy, very interesting topic in my opinion. So now I can start. Okay. So as I mentioned, I wanted to take this opportunity to look into the Physician End-of-Life Option Act that is being enacted across California, mostly because it's an exciting, interesting new topic. It opens up new frontiers, but it's also a very divisive topic. People in the medical community feel very differently about it. Some people are very in favor of it, some people are very against it. So I wanted to use this opportunity to kind of explore the landscape, look at what's been done in the past in Oregon and Washington, and then look at what the perspectives are like both in the legal and medical communities as well as amongst the patient population, and then ultimately what does this mean going forward. And so I'm going to start with an overview of palliative care, go through some case studies and perspectives, and then talk about what comes next. So I started with this slide just to provide some basis for what end-of-life care options are. I think palliative care gets a really bad reputation for being kind of the death group, the group that comes to talk to you about end of life, comes to talk to you about hospice. But actually, palliative care is really much more about helping people live well at all stages of life. As Rebecca knows in the ABC project, so many of the patients that they see have months, even years to live. But Dr. Raybo and Rebecca and the other SMS providers really work with them to help manage their fatigue, help them manage their nausea, help them manage constipation, so that they can manage their symptoms and live well at whatever stage of disease they're in. Hospice care is when patients have 6 months left, that prognosis of 6 months. They no longer get any curative treatment, but they do get palliative treatment for their pain. Palliative sedation is an interesting area in which patients are induced into a coma, mostly to help manage pain, and it's not with the intent of ending life, but it's to manage pain. The ultimate result is because patients are put in a coma to manage their pain, they end up not getting nutrition and end up passing away from lack of nutrition and water. Physician-assisted death is the prescription of medications to patients so that they can self-ingest in order to end their life. And then euthanasia is the lethal injection that physicians provide to patients at the end of life upon request. So The California law is about physician-assisted death, which is one of those things on that spectrum of care. There are a lot of arguments in favor and against it. The biggest argument in favor of it is that it provides patients with an opportunity for control. It gives them an opportunity for death with dignity, and it gives them an opportunity to end their own suffering. But on the same side, there are a lot of reasons against physician-assisted death. For one, people claim it's a slippery slope. If we start with patients who are terminally ill, then where do we draw the line? What about patients who are chronically ill? What about patients who have mental illness? What about vulnerable patients and populations of minorities or disabilities? What do we do with those? You're kind of really getting into a gray area where there are a lot of unanswered questions. It's also potentially a conflict of interest. Hospitals, unfortunately, are profit centers. And so there are questions as to whether hospitals might incentivize physicians to hasten patients' end of life to save costs and ultimately be more efficient. And then there's role conflict. A lot of physicians go into medicine, they want to be healers, they want to be able to help patients with their illness, and a lot of physicians feel conflicted taking on this role of helping patients ultimately end their life. So what I did next then was to go through surveys on what perceptions were from physicians about end-of-life care. And so from this graph, what you can see is the willingness to participate amongst physicians was much higher when assisted death or euthanasia was considered legal, much lower under current legal constraints. This survey was taken in 1996, so that was just when the Oregon bill had passed. Most other states had not enacted any kind of physician-assisted death laws. But even though it wasn't enacted in law, a lot of physicians reported having patients come to them with requests for physician-assisted death or euthanasia, and some even participated, opening up kind of a can of worms that even though it wasn't legal, it was something that was still happening and just swept under a rug and didn't allow for an open conversation. What was interesting about all of this was that the greatest willingness to participate was amongst neurologists and pulmonary specialists, but the highest number of requests was amongst oncologists, geriatrics, and infectious disease physicians. Then I took a deeper look into the oncology perspective. So what this was a 1996 survey looking at oncologist perspectives, oncology patients, and then the general population, looking at under 4 different cases if patients have terminal illness with pain, debilitation, burden on family, and then life is meaningless. How do people view the opportunity for physician-assisted death? And so what was interesting about this is people were most in favor of providing physician-assisted death when patients cited pain as their primary problem, and then people were least in favor of it when people cited life as meaningless as their most prominent problem. So then I went ahead and looked at what was happening in Washington and Oregon. And so as we can see here, at least in Oregon, a majority of the patients who actually, or a fair percentage of the patients who actually get the prescriptions don't use them. So it's about 2/3 of the patients who actually follow through with using the prescriptions. The same is not true of Washington, but of note is that a majority of the patients who do request this are on hospice, and even then, the number of patients who are requesting physician-assisted death is relatively low in comparison to the overall patient population. What this means for California is that experts say about 1,500 people a year will ask for physician-assisted death, with about 2/3 of them actually following through on them, which is about 1,000 patients per year. But it's hard to say because unlike Oregon and Washington, California is a large populous state with a huge minority population. It's much more different than the patient populations you see in Oregon and Washington. So just to go over kind of the basics of the California law, it is a voluntary act. Physicians are not forced to participate, and patients should not feel coerced into choosing this option. Patients must be greater than 18 years of age and must be able to self-ingest the medication. There must be no mental illness that's actually driving the depression. So the way people look at this is patients can be depressed, but the depression cannot be actually driving their decision. They must have a diagnosis of less than 6 months, 2 oral requests made within 15 days of each other, and sign off by both a consulting and an attending physician. Currently, the Kaiser, the UC system, and Sutter have agreed to participate. The VA and Catholic hospitals are not participating. A number of hospitals have not made a decision yet. So I took a look at first the legal and ethical perspectives on this. There was a task force back in December in which there was a panel on ethics and what this means ethically. One of the biggest concerns that was brought up was insurance and access. A lot of drug companies are marking up the prices on these drugs, which makes it a lot more difficult for patients who don't have good insurance coverage to actually get access to it. So are we disadvantaging patients without good health insurance, and therefore are we disadvantaging patients from a lower socioeconomic class? The other major question is what are we going to do with the fact that legalizing it doesn't necessarily mean or remove the stigma of suicide. There was a lady who cited from Oregon that people still thought of this as suicide, and so it doesn't remove that stigma and doesn't open up the conversation as much as one may think. Physician perspectives come from two different ends. Some physicians are very positive about it. As you can see here, one physician noted that this law opened the door to having conversations about palliative care with her physicians and opened the door and the opportunity to talk about end-of-life care and to have an open discussion and bring out issues that they weren't able to bring out before. But on the flip side of that, a lot of physicians see a lot of negative effects of this. I think the biggest concern people have is that we're jumping 10 steps ahead. Not a lot of people have access to good palliative care, and we shouldn't use that lack of access as a reason to be handing over lethal medication to patients. And so there's kind of a gap. It's like, we provide some palliative care, no palliative care, and then here you can have a lethal medication. A lot of physicians see that as a major concern. A lot of physicians also are concerned about seeing certain groups kind of become the death squad. So oncology, geriatrics, palliative care are going to become the providers who contribute most to this, and people are concerned about how they're viewed by patients and by society. Patients, on the other hand, are overwhelmingly in favor of this. One survey said that 70% of patients were in favor of physician-assisted death. And as we all remember last year, in the case of Brittany Maynard, who really snowballed this effect in California, moved to Oregon in order to be able to have access to this opportunity, and that is what really got legislation going forward in California. So what does this mean going forward? As of now, it's law, and so whether or not people are in favor of it or against it, we have to find a way to effectively implement it. And the best thing to do is really to train physicians and train providers on how to have conversations with patients about end-of-life care and make sure that you are really talking to patients about all the options that they do have. And many physicians cited that when they had these conversations, they were able to address symptoms that reverse patients' opinions about physician-assisted death. And the other important thing is really just improving policy and creating financial incentives for physicians and for hospital systems to provide patients with good palliative care. That being said, I wanted to say thank you to everybody for the last couple of years. I want to especially say thank you again to Rebecca again for introducing me to the symptom management service, and for that team for really introducing me to this topic and for giving me an opportunity to learn about what I think I want to do in the future. And so I sincerely appreciate that, and I sincerely appreciate the other opportunities I've had here. So.
I knew I left this somewhere. I thought one of the slides that was really telling to me was the graph you had that showed like 56% of patients being in favor and like 9, even when the oncologists were in favor, 9%. That this one. If you look at the difference between the patients and the physicians, I want to point out that almost every major change, so we're in the field of breast cancer. Breast conservation did not get here because physicians led that change. The ability to get rid of radical mastectomies came because patients insisted, and they refused to continue to have things a certain way. And I think it's very interesting that this program is all about shared decision making. And I like your take of framing this as a shared decision making. I mean, that the patients are doing that. I think when there is this kind of a gap, there's opportunity, right, Jeff? That what Jeff is going to teach you guys this year is about what's in the patient's mind and what's important to them. So my question to you, Mamta, is for the detractors of this law, it's not, the fact that we have this law and someone feels like they can legally bring this up and have this conversation
is that what starts the conversation? Is that forcing physician's hand to end it, or is that really just a good thing because then people feel the barrier to talk about wanting to die is
Yeah, I
important?
think that being able to have an open conversation about this will help educate patients about what other options they do have. I think it's going to, like in the Oregon law, a physician cited a greater percentage of increase to hospice referrals. So I think that it's going to open the door to thinking about other end-of-life options. But I also, equally on the other end of that spectrum, I see the concern that people have in terms of how is this going to be implemented? How is it going to be implemented effectively? How are you going to prevent certain specialties from being seen as the ones who are the primary providers of this? So I think there are a lot of I think there's a lot of upside. I think there's a lot of downside, and I think the real solution is how do you educate both patients and physicians to have these conversations.
So my name is Ian. I'm going to talk to you guys today about the quality of life sub-study, which is part of I-SPY 2. The quality of life is it's a project that basically is designed to look at patients and see how are they responding in a more holistic sense to 6 months of chemotherapy treatment, neoadjuvant. So I'm going to talk a little bit about the background of I-SPY and go into some of the founding ideas behind the quality of life study and how it's done. Then I'm going to talk about our findings. And then last, I'm going to go on to what we can improve about the way it's carried out and what we can do in the future. So what I want to get you to think about today is what is it like for these patients as they're going through this chemotherapy, and what can we do as a hospital to make it better for them? So that's what this quality of life project is aimed at, assessing multiple aspects of quality of life during I-SPY treatment and beyond. Oops. So we're looking at patient-reported outcomes, so on a survey, and connecting that with tumor characteristics, HER2 positive, HER2 negative, ER positive, ER negative, etc. The chemotherapy type, that whatever treatment they've been assigned to, and surgical outcomes, so PCR rates, and seeing how do anxiety, depression, physical functioning, etc., how are those impacted? So this is a basic overview of I-SPY. The first 12 weeks they get paclitaxel, and if they're assigned to an investigational agent, they will also get that during that first golden portion. Then AC for all patients, followed by surgery. So again, it's approximately 6 months. So the surveys we administer come in here. You can see we're collecting data pre-treatment, during treatment, and before and after surgery. So for the current analysis that I'll be showing you today, we have 48 patients who had the sort of full profile from pre-treatment to all the way post-op. And we do have more patients, but it's kind of, sprinkling. We're missing a couple of surveys here and there. So the measures we used are two measures that are well established: the European Organization for Research and Treatment of Cancer and Participant-Reported Outcomes Measurement Information System. Both of these look at physical functioning, anxiety, depression, and we constructed our surveys from those. Here's a little example from one of the surveys. You can see it's just having to do with physical functioning, rating them from 1 to 4. And that's our data. Okay, so our findings. Again, this is with 48 patients, so it's a bit limited. But we have physical functioning scores, and we see that they decline throughout treatment, and they come back, but not quite to where they were at baseline. And this is true for both the PROMIS and EORTC measures. Interestingly, we found that the EORTC baseline and postoperative, so the dark blue, there was no statistical difference between baseline and postoperative, whereas PROMIS did show a difference. So that suggests that the PROMIS measure might be better for patients who are not severely incapacitated. Patients on I-SPY might be a little more sensitive measure. We also found that HER2 positive and HER2 negative patients showed similar patterns of recovery, which is interesting because they do receive slightly different treatments. Okay, and now the anxiety depression data. This is very preliminary. We just kind of put this together this week. This is just It's not with the 48 patients. This is just including all patients from 5 sites, so about 148 patients. And what we did is we just took the average at each time point and looked at how much anxiety in this case and depression, you'll see in a second, is at each time point. So you can see that the anxiety tends to decrease once patients go on study. Once they start receiving treatment, their anxiety drops. Again, this is very preliminary, so just take it with a grain of salt. And then the depression data, you can see that it's more or less constant throughout treatment, and then there seems to be a significant drop after surgery. But again, preliminary. Okay, so things to keep in mind with this data, we're missing a lot of surveys. The way we collect surveys is we go down to, as clinical coordinators, we go down to the clinic, hand out a survey, ask the patient to either fill it out then or bring it back the next week. A lot of times we just don't see those come back, and they just they're off into the ether. So we're trying to get this, more systematic, and so we can get more data. Our current analysis is descriptive rather than inferential, and we only have data from 5 sites. So there's a potential there for bias because these 5 sites are large institutions. So it could be that their anxiety and depression of these patients at large institutions is different from patients who are at smaller institutions with less resources. Okay, so now going on to the future, what we can do to improve. The first thing I would like to see happen for quality of life is more streamlined data entry. So this would be either on REDCap or Qualtrics or Salesforce, maybe integrating with the one-source checklist. It's possible we could, like the new patient questionnaire when patients come in to see a new oncologist, if we had a quality of life survey embedded there, we could actually compare do patients on trial versus off trial, show differences in anxiety and depression, which might be cool. Good thing to look at. And then other things we want to look at, these are bolded because I think they're the main things that have come up in discussions that we want to look at. So comparing anxiety and depression, physical functioning between treatment arms, so patients on pembrolizumab versus an AMG drug versus the standard of care, etc. Also looking at anxiety and depression with regard to the residual disease, so if they had like a PCR pathologic complete response versus still a significant amount of disease at the time of surgery, we would think that would influence anxiety and depression. So that'd be good to look at. And then we want to look at whether adverse events are a driving factor for anxiety and depression, and seeing maybe that's the reason. And we'll have to pull that data out in the future. Other potential things we could look at, mammoprint risk and see how that influences anxiety and depression. Looking at surgery type, mastectomy versus lumpectomy, looking at hormone therapy, and also patient demographics, age, etc. Okay, so the takeaway, what I'd like you guys to think about, we really want to make sure that we're thinking about patient anxiety and depression in terms of what their tumor looks like, the pathology, what kind of chemotherapy they're getting, and their surgical outcomes, and seeing if we can improve our process of providing care for them. And if we have this data, it'll add to what we can tell the drug companies about the drugs they're giving us, and allow our physicians to make more informed treatment decisions. What I'd like all of you guys to do is, if you encounter an I-SPY patient, ask them how the quality of life surveys are going. Encourage them to fill out the surveys. They are like 7 pages, so it takes a while. They might need a little encouragement. And that'll give...
If you get it electronic.
Right. That would be best. But in the meantime, and then if we have better data, we can make more informed decisions about, should these patients go on trial? What's it going to do to them in terms of their emotional health and physical health? And ultimately, that'll influence treatment decisions for our institution and also others. And it'll allow us to improve the care we provide. So on that note, I'd like to say thank you to Dr. Maliska, Manta, and Christina. So the help was invaluable there. Really appreciative. Thank you.
Sometimes she wears her hair down. Anyway, thank you. So, okay. Before we open for questions, Ian, so just in case, and Manta's going to have to come back up and talk about this, since what is looking back on the year, what is the most important thing you think you got
out of this program? Or what was the most important?
I'd say it's maybe a bit cliche, but just all of the people that I encountered here. I think especially as a coordinator and doing PSC, you get to interact with hundreds of people at this amazing place, and everybody has their story, everybody's passionate, motivated, caring, and I'm really grateful for all the connections that I made. I just wouldn't trade that for anything.
It was great. Thank you. I'll tell you in a moment.
So questions that we have for Ian.
So Ian, what I think you brought this up, and you know, I've often been asked, like, why can't we just do REDCap, or why can't we just do XYZ? Why can't we just sort of get things up? One of the problems in medicine is that, you know, sometimes you know, we often do the things that is most expedient to solve that problem. So being able to get an electronic survey up right away would be certainly helpful in the short term. Having common platform across what we do, what would the advantages of waiting and doing it that way? What do you just from looking at it? And you maybe alluded to a little bit of it in your conversation.
Well, I think we could target it to patients at much more precise time points. And if they can do it in the comfort of their own home, I think they're going to be more likely to do it. We can send out reminders. I think the number of surveys that we get back and the amount of information will go up massively, which
Right.
is hugely important.
And
also it can be integrated into other
Right.
studies and used in clinical
care, and so you can
yeah.
see what the different, I mean, I think one of the things is having a common platform allows you to look at care versus research versus not, really, you know, allow you to compare and make it more of a routine as opposed to something that's like an intervention all the time. Melissa?
Nice job, Ian. You obviously had addressed expanding the idea of the quality of life survey to other institutions within the ISPEC program.
Right.
The large and small. You also mentioned how to integrate the survey into looking across the general population of patients that are going to receive chemotherapy, so non-trial patients, is interesting. How might the data be examined against the general population? So you could potentially look at how age or other factors potentially weigh into how we're looking at depression and anxiety in our patients.
In order to get that sample, I think you'd have some challenges, but it looks like Dr. Meliska.
Yeah, I was going to add that, so one of the things that you commented on, and I just would just further acknowledge, I mean, one of the main goals of this trial is that promise is actually not well validated yet in the cancer population. And so that's what makes this quality of life study so novel. When we designed this study, we collaborated with a woman from Georgetown who is a measurement specialist. I mean, that's her PhD is in measurement. You know, the idea of being able to look at this what's called legacy quality of life questionnaires like the EORTC, which I should add, you have to pay for every time you administer an EORTC questionnaire. And had it not been for the grace of Laura Vanvier, who got us in dispensation to use it for free, it would have cost us about $35,000 to use the EORTC surveys for I-SPY for the number of patients that we had intended. So the NCI and NIH developed this PROMISE set of item banks, which is largely validated in the general population, but there's now an effort to validate it in the cancer population, and our study right now probably stands as one of the largest of the trials ongoing and the earliest that was initiated to validate the PROMISE in the cancer population. So even though, I mean, there's a lot of flaws in the data, I think we have this amazing opportunity that we have the infrastructure in place to be really a leader in the utilization of this quality of life group of questionnaires and items that will then become the standard of care across the world, at least in the United States, but possibly across the world.
And I have to say, I'm going to say this is Kim Couteau's doing. He actually worked when he was head of the cancer bioinformatics grid at the NCI. He did this, plus, you know, he's buying up the SNOMED codes, try and make the standards and structures open access and free. Without that, I mean, that's just a huge barrier. And if we want quality of life to be part of the standard of care, it can't be something that costs us something to ask somebody every day. And so I think, hi, Hope, how are you? And I think that again, this idea of there's a method to my madness. So this idea of really trying to get the resources to have this be the standard of care in our day-to-day care and the standard of care in our trials allows us to ask those questions, just as you said, Melissa. How does this look? How can we roll this out to other sites, and how do we know how it's compared to like your standard of care? Because you can actually look, because we'll have it on everybody. That's just, it's like getting blood pressure, or it's like getting something else, and that's actually something that Michelle and I are working on with the FDA through the Associated Center of Excellence in Regulatory Science by making it part of one source checklists on the patient side. That April hopefully will talk a little bit about, but we these are really big changes. Sadly, they take a long time. Timberlake just walked in and has been started working with me. She was my employee number 2 after Debbie Palbociclib, actually at the Breast Care Center long ago. She's, for the new interns, she's going to be your coach to help make these fantastic presentations. I hope you've been listening to me to say this, and Jeff probably has listened to me here and say it for even longer, since 1991. Yes.
I just wanted to pick up on a comment you made that if we're going to do this on a large scale, we can't be paying every time we have a survey. So I just want to express from the social behavioral medicine point of view, if we're not paying for surveys, if we're not
We're going to pay for the analysis of surveys.
No, but if you're not willing to pay for the survey itself as if it were a drug, when we pay for drugs, we won't have more investment in measurement and all that kind of stuff. Mm-hmm. So there's a bias in healthcare around, okay, we can pay for biomedical interventions, but the social behavioral medicine stuff, like what I do, is not really worth paying royalties for or worth recognizing intellectual property on. So I understand that with digital and information products, the marginal cost of delivering is free. It should be free, so you want to deliver it free. But you have to just recognize that there's an engine of development, intellectual property development underneath that isn't getting compensated. So,
well, I think there's more than one way to skin that cat, and that's what we'll talk about tomorrow. I hope everyone's going to be there tomorrow, because there is like the analysis of it, and we have to talk about what drugs are. And I hope you'll bring some of that up, because there is, we get into this all the time. This is a big argument, believe me, over all the tools, the one source checklist, and all these. Are they can be free? Are they can be open? The problem is, if you want them used by everyone and disseminated and have a standard around them, you make a bar to using them, that's a problem. So this is a Mike Hogarth conversation as well. Are we going to be proprietary about what we do or not? That's why we have this intellectual property commons. I don't think that we have a perfect answer, but I don't think, I think giving away that IP, and I think where the IP is creating organizations around how you use them and how people organize them. I think there's different ways of getting the investment that we want, but I think doing it that way and putting a premium on them just puts such drag on the ability just to spark it and get going.
So I guess I can start with saying what I learned over the year.
Good job.
Yeah. So moving forward, I will start with that. I think the most important thing that I've learned is learning that it's okay to say I don't know to both patients and to physicians, and whoever you're working with can always say, I don't know, let me go check on that for you. I'll ask whoever I need to ask, and not to make anything up on the spot when you're in a pressured situation.
That, if you guys could just learn that lesson right now, it'll save you a lot of time and eggs.
Yeah. Okay, so over the last year, I've been a clinical coordinator for a couple of drug trials in the adjuvant setting for a drug called Palbociclib. And I had heard over the year a couple of different differences between patient populations that take this drug. And so I wanted to look in and see if these things that I had heard were actually true from doctors, both how I had experienced it and then how other drug trials were experiencing it. Okay, so first I'll go over a little bit of background of the drug Palbociclib, since I'm sure many of you are not familiar with it, and then the clinical trials and how the background of those trials also, and then I'll go through the analysis that I've done so far in terms of adverse events, as well as patient compliance and withdrawals on these studies, and then a little bit about what I hope to accomplish in the future, or what maybe Martina will accomplish in the future, and she'll be working with these patients as well. Okay, so first of all, the drug This drug is used only in patients who have estrogen receptor positive cancers. And so what that means is that the hormone estrogen fuels their cancer, along with a number of other proteins, in particular.
I'm just going to move the mic over because we're taping it.
So in particular, estrogen fuels the cancer, as well as a set of proteins called CDK4 and 6. And so together, estrogen and those proteins help cancer cells grow and divide out of control, which is obviously not a good thing. And so what has been used in the past over the last 10 or 20 years or so are drugs called endocrine therapies, which actually suppress or reduce the amount of estrogen in the body so that cancers are not fueled by the estrogen if they're estrogen receptor positive. And then this drug Palbociclib, or also called Ibrance, actually inhibits that other protein I was mentioning. So together, letrozole or other hormone therapies like tamoxifen or Faslodex, those together with Palbociclib slow the growth of estrogen receptor positive cancers even more so than the hormone therapy alone. And so the drug Palbociclib is an oral pill that patients take along with endocrine therapy on a cycle of 28 days. So they take the drug for 21 days, and then they take 7 days off of the drug to allow some of the side effects that the drug causes, to allow their body to recover from that over that 7-day period. And then they start the cycle over again then after those 28 days. Okay, so just a brief overview on the difference between adjuvant and metastatic trials, since maybe some of the new people might not know what that means. So an adjuvant treatment means that a patient has already had surgery for their breast cancer. The cancer is removed. Theoretically, there shouldn't be any cancer left other than maybe or in the bloodstream or something. So an adjuvant treatment is to help reduce the risk of the cancer returning, or to fully eliminate the cancer after it's already been removed. And then a patient with metastatic disease in the metastatic setting already has disease that's by definition incurable, has already spread, and the hope is that their cancer will be kept at bay, per se. They won't progress any further, or their cancer won't show up in any of their other organs. And so there have been a few trials that with the drug Palbociclib, and 2 of them were opened at UCSF. These 2 trials that I show here opened in 2013 and 2014 at UCSF, and they looked at the drug Palbociclib in metastatic patients. And drug trials usually start in the metastatic setting to see if they're going to be effective, and then they move to test and see if this drug will be effective in adjuvant patients. So these trials opened first at UCSF, and they used 2 different hormone therapies, 2 slightly different patient populations, but they both were randomized trials where some of the patients received a placebo and some received the actual drug. So 2/3 received Palbociclib along with their standard hormone therapy, and 1/3 received only the hormone therapy. And both of these drugs together, or both of these trials, led to an expedited approval of Palbociclib in the metastatic setting. So patients that are taking either of these 2 drugs under certain conditions can actually now take Palbociclib as a standard of care because it slowed the time for their disease progression. So it took longer for their disease to either spread or show up in other organs when they're taking Palbociclib in addition to their hormone therapy. So after a drug is approved in metastatic trials, it can then be we can look at it in the adjuvant setting, which is what we're doing now. So there are a couple of different trials open at UCSF, there are about 25 patients on those trials. And these trials look to see if Palbociclib will both be feasible and also effective in the adjuvant setting. So effective in reducing the risk of their cancer returning, or just being feasible in general. Can patients take this drug over, according to how they're supposed to take it instructively, and then also, is it effective? So I looked in a little bit into what I was saying before, how a lot of physicians were reporting that patients in the adjuvant setting, so they're theoretically cancer-free and hoping to prevent their cancer from returning, they were reporting more side effects, in particular fatigue, which is a main side effect of the drug, and more so than in the metastatic setting. So I wanted to look and see at UCSF, was that actually the case? And so what I found was that 35% of patients in the metastatic setting started with fatigue, and that was less than in the adjuvant setting, but more patients overall reported fatigue in the adjuvant setting. We don't have a pointer, do we?
You can use when you scroll around with your mouse.
Okay, well, that's all right. So as you can see, there's a greater differential for patients who developed fatigue in the adjuvant setting than in the metastatic setting. So more patients were developing fatigue or reporting this fatigue, and physicians were writing that down. This is a little different than a quality of life survey. This is reported actually in a clinic note. And then also another side effect that's common for the drug is mouth sores. So I looked into that, and adjuvant patients reported slightly more mouth sores, although we can't really say that that's very significant. So I also wanted to look in a little bit more into the fatigue in the adjuvant setting. Why are so many patients reporting more fatigue over the study, and also how does that compare with the patients that start with fatigue? So we call baseline fatigue. I wanted to look at patients who had baseline fatigue and see where that fatigue was coming from. And so what I found was that patients with that started the study with fatigue, those patients had finished chemotherapy more recently than the patients who did not report the fatigue at baseline. So those patients are likely tired. They have just come out of having surgery, radiation, chemotherapy, and so those patients start the study with fatigue and then either had fatigue throughout or developed worsening fatigue. So this bottom statistic, the 68% of all patients on the adjuvant trials developed fatigue, so went from no fatigue to fatigue, or developed worsening fatigue, and that's compared to only 50% of patients in the metastatic setting developed that fatigue or developed worsening fatigue. So it's a little interesting to think, well, patients who have metastatic disease and actually have known disease in their body are reporting less fatigue and less side effects than those who are disease-free. So I also looked at the patient compliance and withdrawal statistics. So I defined patient non-compliance as patients who either didn't show up for clinic visits, didn't show up for blood draws, didn't return pill compliance diaries or pill bottles, or follow instructions after multiple reminders. I called that an incidence of non-compliance, and I looked at those incidences in adjuvant patients versus metastatic patients, and then also withdrawal rates. So patients who decided to come off of the study on their own account, not from disease progression or physician opinions. And so patients in the adjuvant setting were greater in both of these categories. More incidences of non-compliance and also higher withdrawal rate, much higher withdrawal rate, because patients in the metastatic setting are as we can imagine, are less likely to withdraw from a study when they think or know that this drug is going to be helping them keep their cancer from progressing, versus patients who they don't have cancer, so they're wondering why they're on this trial some of the times and they end up withdrawing. So before I go into some of the takeaways, I want to say what I hope to look at in the future. Hopefully do some statistical analyses, bring in the fact that there is a placebo involved. How does that come out statistically? And then also, how do we tease out side effects from hormone therapies? Patients on these trials were taking a number of different hormone therapies. How do we tease that out from the Palbociclib? And then also, it's really interesting to note that all the patients that have dropped out of the adjuvant trials were on the trial that does not have a placebo. So everyone knew they were getting the drug, yet 5 patients still dropped out of the trial, whereas we have another trial that is a blinded study, randomized. Some patients get the drug, others don't, and those patients have been more likely to stay on the trial. So is that a psychological effect of they, kind of taking advantage of the fact they know they're on the drug? Okay, well, I'm going to drop out now. It's just an interesting caveat. also looking at this, how does age, stage, and treatment delays play into this, and then other adverse events and quality of life. But I do want to leave you with just the interesting note that the early stage patients who did not have advanced disease did report more, developed more fatigue, either worsening or overall, and then withdrawal in adjuvant trials. It's a really interesting situation that a lot of patients are dropping out in this adjuvant setting, and is that universal for all adjuvant trials, or does it just have to do with this drug palbociclib? Is it a problem with recruiting? Are we recruiting the wrong types of patients? And also, what can we do to help patients prevent patients from dropping out in order to reach statistical endpoints more quickly and get drugs approved in the proper settings? And I just want to say thank you to everyone up here. Amy DeLuca is in the back. Thank you to her. All the clinical coordinators, Sally, Fang, and Melody helped me get some of the metastatic data, and then everyone up here.
Thank you very much.
Yeah.
So I'm going to bring up my favorite topic, of course, which is neoadjuvant therapy. So I think, I've done a lot of trials in screening, in prevention, in surgery, in neoadjuvant, adjuvant, across the spectrum. And I actually am very familiar with so many issues about people dropping out, and whether people are, and even once you have demonstrated that particular drugs work, even in the prevention setting, why don't people take them? My experience is that people want to know, do they truly have risk? So metastatic patients know they truly have risk. I think that's one of the reasons why they're more adherent. We like that word better than compliant. Adherent. Then the second thing is you have to say, are the treatments we're providing something that people are enjoying or not? So the fact that they're not adherent is giving you a message. A third of people drop off their hormone therapies because they don't like the side effects. I mean, that isn't their being bad. That's them giving us a message about what they think of our options that we're providing them. The last thing is people really want to know, do they in particular benefit? In the adjuvant setting, what are some ways, how could you imagine we could maybe address that question better? How could we get better around that? Because I think that in the end is the key to all of this. What's an early endpoint? How can you figure out? Any ideas?
An earlier endpoint than disease recurrence? Or?
Which can be 5, 10, 20 years later. I mean, most people aren't quite that patient, me especially.
Well, for the phase 2 feasibility study I was talking about, the one where everyone gets the drug, the endpoint for that study is actually not disease recurrence, it's actually patients dropping out of the study. So I think they're looking at if a certain number of patients drop out of the study before it's over, they're declaring that it's not going to be a feasible treatment for patients in that setting.
Well, what if you gave the drug in the neoadjuvant setting?
Oh,
we
yeah.
Sorry, my favorite topic. Why is it my favorite topic? And is there a way, would you just give it to everyone if they're responding, okay, but would you give it with and without?
And then see at surgery where
they are, or to see, do you think if people knew that they in particular seemed to be responding to it, that would change their motivation?
And then they would take it again after surgery?
Yeah, so the decision to take it afterwards would be based on whether or not they had any response, right? Mm-hmm. Now that's not how we do it, but I honestly think these big, long studies, I mean, there's the New England Journal, the New England Journal of Medicine was devoted, half the journal this month was devoted to I-SPY. Yay. But not, so we had our 2 efficacy articles, there are 2 editorials there that I think are really interesting, plus a review of trials. And thinking about these adaptive trials. And I have to say, we are not in I-SPY where I want it to be. I want us to be adapting within patients. We will get there somehow, someday. But I think the big issue here is, how do we get there? Again, you guys are the future of medicine. We have to push ourselves to be thinking, how do we get an early endpoint?
How do we get a readout on whether someone's responding? People are motivated. I mean, and again, you have to think about it. Flip it and take it the way Jeff thinks about it. Patients are coming to the table to make a decision. It's a shared decision making. You know, we can't look at it as like they're in our trial, they're not, or they're compliant with our medicine or not. When they drop out, as a customer, they're saying what? Sorry, it's not worth it to me. That's an important endpoint. It's an important endpoint. So what we want to know is if they knew they particularly benefited from it, how would that impact their decision to stay on it? And if the side effects outweigh the benefits even then, that is an important point to your drug makers. Make a better drug, or find something that has fewer side effects, or something else unlike that, that people aren't willing to take things for 2 and 3 years just because the drug companies want to administer it for 2 or 3 years and get a bunch of money from it. Doesn't mean the patients want to do that. You don't work for the drug companies, you work for your patients. So I didn't say early endpoints were easy, and that's what this New England Journal article talks about. Are biomarkers good enough? Are these early endpoints good enough? They may not be good enough forever, but it's the start. We have to demand better endpoints. Early endpoints, something that gives you an early idea of whether your drug is working. And it's a start, and we have to keep making it better. That's the point. And I think that is what's so interesting. I think that data is very interesting about what people are willing to do and not to do.
I think it'll be interesting to see how, the drug was overwhelmingly effective in metastatic patients, but is it going to be as effective for the adjuvant setting, and is it worthwhile for patients to take the drug with all the side effects and all of the different things?
So perhaps it should only be given to those people who really need it. Remember, the drug company wants as many people to take it as possible. But that's not our goal. Our goal is trying to figure out who needs it and how long should they really take it. So these liquid biopsy companies and these circulating DNA, these are the kinds of new markers that could really, unleash the power of our ability to tailor treatment in patients. So.
Okay. Well, good morning, everyone. My name is Brianna Johnson. I am an intern in the Campbell lab. And I'll start with talking about 2 of the big takeaways that I got from the Breast Care Center internship. I'd say the first one was it's been great working on this project under the guidance of Dr. Laura Esserman and Dr. Mike Campbell. It's been really interesting seeing how bench work works with the clinical side and kind of how they integrate. I started the BCC just having worked in a lab for 2 years, which was great, but I didn't know how we could integrate all of this research into the clinic. And then I think my second takeaway is I've gained a great appreciation and admiration for the nursing staff. None of this would have been possible without Debbie Homolsky and Sarah Golden. They were a great help in recruiting patients. Okay. So the big question we're going to be talking about today is there a link between the microbiome and breast cancer? This is an exciting question because while there has been a lot of research looking into the link between the microbiome and disease, there hasn't been that much specifically looking at breast cancer. So what I'll be doing is giving a quick overview of the current research in the field. I'll be talking about the findings from this year. Tess O'Meara presented last year on the pilot study, and I'm excited to talk about what we've been up to since then. And then I'll be going through next steps. Emma McCune will be the intern in the Campbell lab for next year, so she has some exciting work ahead of her. So the first question, what is the microbiome? The microbiome is the collection of the bacteria and foreign microbes in the human body. But it's interesting because although these microbes have been evolving since the origin of humankind, we don't know much about them. Just to put it in perspective, microbial cells outnumber human cells 10 to 1. When we look at the genome, they outnumber the human genome 100 to 1. This is why everyone's so excited about sequencing the human microbiome. And if you think about it, our brain weighs up to 3 pounds. The human microbiome can weigh up to 6 pounds. We know that microbes facilitate daily bodily functions, such as appetite, metabolism, immune function, and brain development. But it wasn't until recently, thanks to large-scale parallel sequencing, that we've really got to look at this link between the microbiome and disease. We're even starting to look at the different sites in the body and see how bacteria varies among those sites. So today we're going to be talking about 3 different microbiomes. First, we're looking at the oral microbiome. Researchers know that microbes cause inflammation and periodontal disease, or gum disease, and they've also found an association between an increased risk of breast cancer and periodontal disease. They think maybe one of the big factors is inflammation, which can lead to secretion of cytokines, growth factors that inhibit anti-tumor immune function. They've also looked at research surrounding chronic antibiotic use, as well as the link between differences in the oral microbiome and oral cancers and pancreatic cancer. Because of these findings, this motivated Dr. Mike Campbell and Tess to look at the oral microbiome last year. And what they did is they compared 12 breast cancer patients with 10 age-matched healthy patients. They found a difference in Streptococcus and Prevotella, with Streptococcus being more abundant in healthy women and Prevotella being more abundant in breast cancer patients. It's interesting to think about these differences. Maybe there's a way we could develop an early screening test. Maybe there's a way we can alter the oral microbiome and shift patients from a cancer microbial profile to a healthy microbial profile. We're also going to talk about the gut microbiome, which has been studied. They've studied the association between the gut microbiome and cancer, specifically in the context of specific microbial species, as well as the dysbiosis of the gut microbial environment. Some of the interesting findings they found is that there's H. pylori colonization has been linked to gastric cancer. They've also found that Fusobacterium nucleatum is a species that is overrepresented in patients with colorectal cancer. And then the last microbiome we're going to be talking about today is the breast microbiome. Breast tissue was thought to be sterile up until 2 years ago, when scientists confirmed that microbial DNA is present in the breast tissue. The reason we want to talk about the microbiome is we think these microbes could be stimulating resident immune cells. So if there's a dysbiosis of these microbes, perhaps that could be leading to a cause of breast cancer. So the objective today is we're going to be comparing these 3 microbiomes in 3 different cohorts of women. Women with invasive breast cancer, women with ductal carcinoma in situ, and a healthy woman population. So raise your hand if you've seen one of these kits. Raise your hand if you know what's in them. Okay, I'm going to be passing around this kit so you can see what we hand out to patients. Patients receive this kit before starting any systemic treatment, whether that's hormone therapy, chemotherapy, or radiation. And what they do is they just take 2 samples. One is a cheek swab, so they swab their cheek in the morning before they brush their teeth. And then for the gut sample, they take a swab from their toilet paper. They then sent these samples to Ubiome, a company we were pairing with. Just a heads up, if anyone's interested in getting your microbiome sequenced, you can order a kit from Ubiome and send in your samples. As for collecting samples for the breast tissue, what we did is for breast cancer and DCIS patients, we collected tissue after surgery, and we collected tissue from healthy women from reduction mammoplasties. The tissue was banked in FFPE. So a lot of previous studies have used culture-based methods to try and understand the microbiome, but they came up with issues where they were underestimating or biasing the microbial diversity. We decided to take a genomic approach, and this involved isolating the DNA, amplifying it, and sequencing it. And what we wanted to do was look at microbial abundance and diversity, both at the phylum level, genus level, and a few other levels, as you'll see soon. These were our target numbers. As you can see, we're very close, but Emma still has some work for recruiting a few more patients. Now, before I show you the data, I just want to emphasize the importance of making sure the data is age-matched. Research has found that there have been this ratio between Firmicutes and Bacteroides changes with age. Because we only had 10 DCIS cases at the time that the sequences were returned, For the oral and gut microbiome, we're just going to be comparing healthy and breast cancer. So here you can see a cladogram of the oral microbial communities. You might be wondering, what is this? Well, what's exciting about this is it is kind of plotting the differences in taxonomic abundances, but it's comparing them at all levels. So kingdom, phylum, class, all the way to species. Initially, we had just been comparing them at the phylum level or the genus level, but this kind of gets the whole, all the different taxa. So the ones that we want to be looking at are where there are differences found on all levels. You can see here for the oral, there's some differences at the fusobacteria. The ones in green mean they're overrepresented in healthy populations. The ones in red, overrepresented in the breast cancer populations. So if we look at the gut microbial communities, we can see there's a real difference at the Bacteroidetes phylum. We see these differences, but the question is, okay, what does this really mean? We don't exactly know what the bacteria, the different species, are doing in the gut or in the oral cavity. But we can look at these differences and try and create a profile that might relate to patients with breast cancer, patients with DCIS, or healthy women. We can also start to speculate and say, what are these bacteria doing? There are 3 enterotypes. An enterotype is a way of classifying an organism based on their gut microbiome. And the first one has been associated with an westernized diet. So it's interesting to see that there's an increase in bacteroids in breast cancer patients compared to the healthy populations. I'll now quickly go through the breast tissue aspect of the study. We compared our findings to a paper published in 2014 where they looked at 20 breast cancer tissues and 20 paired adjacent normal. As you can see, our numbers are pretty low, but this is mainly just to figure out the feasibility of the study and to come up with some exploratory data. At the phylum level, all of the samples looked pretty similar. They had the 5 phylum that are listed above, making up 96.6% of the samples. But once we honed into the genus level, we saw some differences. A paper published in 2014 found some major differences between the Sphincomonas genus and the Methylobacterium genus. We found some differences, though not as extreme, so further research should probably be conducted. But it's interesting to think that having this differential abundance in healthy tissue compared to tissue from breast cancer patients might be making a difference. We also found some differences in these 3 bacteria at the genus level. We found that Lactococcus and Halomonas were overrepresented in the healthy populations, and Hyphomicrobium was overrepresented in the breast cancer patients. It's interesting looking at this DCIS cohort and seeing that it's an intermediate. Interesting thinking about what this might mean for how the microbiome relates to the disease. So just to recap over our results, we did find differences in the gut and oral microbiome, specifically looking at bacteroids and the microbiomes of women with breast cancer. We found similarities at the phylum level, but differences at the genus level, which we're excited to learn more about as we expand our study. So next steps for Tess and Dr. Campbell to be working towards. The oral and gut microbiome, we did have some oral samples fail. They were returned back and they weren't fully processed. So we want to start brainstorming different ways that we can collect these samples. We might want to follow up with lifestyle surveys to try and determine if there are other factors influencing the microbiome. As for the breast tissue, we could perform an internal validation set to compare our findings with normal adjacent tissue. We also have 100 cases banked, so we have lots of material to continue analyzing in terms of breast tissue. Additionally, once we have returned all the samples, we'd like to look at correlations between clinical parameters and the microbiota. And all of these clinical interventions are things to keep in mind as our overall goal as we continue to research the microbiome. We want to discover different potential biomarkers that could be used either for screening, for preventative treatments, or for creating more targeted interventions. As we look to understanding more about the breast tissue, it's important to keep in mind that it is hard to determine the difference between cause and effect, but these studies will help us gain a greater understanding of the tumor immune microenvironment as we look towards understanding if these microbes are influencing tumorigenesis. And I just want to thank Dr. Laura Esterman, Dr. Mike Campbell, Debbie Homolsky, Sarah Golden, Jeff, everyone else at the Breast Care Center. I'm very appreciative for this opportunity.
And they especially want to thank me for not killing them. Trail that said, do not enter.
Not that trail again.
Where's that trail again? I love that. Just because they're trying to take it away from us, I will not allow it.
And here are my references and questions.
So really great presentation, Brianna. Since your topic in the lab is the tumor immune microenvironment, so why? What do you think is particularly exciting about the differences in the tissue of breast in healthy people? Why does that? Does that perhaps matter even more than the gut or the oral microbiome?
I think they all have some importance, but the breast microbiome seem to stand out. A lot of the papers we're talking about this dysbiosis, or having an imbalance between different types of bacteria. That might lead to, right. So it could lead to more inflammation, release of cytokines and growth factors. So I think it's really interesting. This is the first time this guy, Ken Pienta from University of Michigan, works in prostate cancer. The first time I heard this was at a NCI kind of think tank brainstorming session when he presented a model of ecosystems. So like when algal blooms come up or things that get out of balance. And it's such an orthogonal model to everything that we think about in science that causes cancer. And I thought, so of course I liked it. But I think that's what I think strikes me about this is that maybe it's not a yes or no phenomenon. It's just a shift that allows things to get out of control, that you could then shift back and get into balance. It's a very different way of thinking about cancer. One last thing is that, so we invited this speaker who's now at the University of Alabama, but he's done a lot of work in the TCGA and trying to look at the bacterial species, at least on the RNA level. The contamination from paraffin is a big deal. Mm-hmm. Are you worried about that, or why do you think that's, why or why not do you think that's a problem? Right.
Because these are not sterile processing.
I've talked with Mike about it, and we're comparing it to the paper that was published in 2014, so we kind of followed the same protocol. I do think it would help if we had more controls, even just a control of, they were talking about using a control of the air and seeing if that would, I think we just need more controls.
We can talk to Tasha in the tumor bank and Scott Vandenberg. Yeah. Maybe we can get them to come today. We'll talk about it. But the good news is that they're all processed kind of the same. So we hope that would balance out. So if you saw it in both, that would be a problem, so maybe it doesn't matter because it's also DNA. DNA is a little hardier than RNA. So I just want to thank Hope for, we started having Hope as our consultant to do PowerPoint, teaching people how to put together presentations that are clear and concise. I have to say, these great presentations do not happen by accident. They happen by design, and this is the design behind it. Actually, you should have Hope come and spend a day with me, actually, because I just thought maybe give a little, just a short spiel about, what you're doing, how, what's your secret sauce, and all of you guys will get to meet Hope because she is your coach for helping you put these presentations together.
This is not prepared, if that's okay. I think one of the things that we've seen, and I've only gotten to see Haley and Brianna's, is ability to interact with the audience. So when we are writing papers, we're writing it with the idea that people can read it, can absorb it, have the time to go back. But when you're speaking, you only have a certain amount of time to engage your audience. So really clarifying what are those 3 key messages that you want to convey, making sure that it's structured in a way that you're identifying or you're defining some of these things, adjuvant versus metastatic treatment, or is that what you're, anyway, the definitions of the biome, what the biomes are, some of the definitions in the beginning. So really thinking about your audience, thinking about how you have a limited amount of time to engage them and educate them, and knowing what those key messages are. And then of course some of the physical things. Just we saw how confident they were presenting, their eye contact, their strong voice, their great posture. And then clear slides, having Haley's section on the bottom where she showed us where she was. They're just really good examples of how to be effective and clear and engaging in your presentations. So thank you for bringing me up now after 2 fantastic presentations, and I'm sure the rest have been or will be as fantastic, and I'm sorry I've only seen a couple.
My name is Sarah, and I'll be discussing the Wisdom study. And this is an exciting time in breast cancer screening generally. A lot of the guidelines are changing. A lot of them have changed within the past year. And so the Wisdom study aims to resolve some of the controversy around how often women should get screened. And it will do this by comparing 2 approaches to breast cancer screening. The first is standard annual mammography screening, and the second is a risk-based personalized screening approach. The study is run through the Athena Breast Health Network, which, as mentioned earlier, is a clinical care and research collaboration across the 5 University of California medical centers, as well as the Sanford Health System in the Dakotas. And this is an exciting study, and because it's a screening study, we need to recruit an enormous number of people, but it also means that the implications apply to the entire screening population. I'll begin by discussing the design of the Wisdom study, and from there I'll go on to discuss the approach we've taken to working with payers and how we're working with insurers to make sure that the study services are covered. So the Wisdom study is a pragmatic randomized controlled trial enrolling 100,000 patients. These participants will be assigned to one of 2 arms, the first of which is the annual screening arm, where they will receive annual mammography screening. And the second of which is a personalized screening arm in which participants will be assigned to a screening schedule based on their personal risk factors, including genetic testing. Participants will be randomized, though if they want to participate but feel strongly about their study arm, they can select that and be part of the observational cohort. And there are 4 eligibility criteria. These are participants must be female, aged 40 to 74, have no prior history of breast cancer or ductal carcinoma in situ, and they must be covered by a participating insurer. Participants can both enroll in the study, that is, they can complete their consent form and they can sign their HIPAA waiver online through a personalized participant platform, and they can also complete all study activities via this platform. They can do online questionnaires to assess their risk. They can receive information back from the study about how often they should be screened. If they are getting genetic testing, then they'll receive instructions about how to complete that saliva spit kit test. And this is a portal that facilitates the fact that this entire study is conducted virtually with online activities. Participants don't need to come into a medical center to be part of the study, which is important given the numbers that we're looking to recruit here. The Wisdom study aims to bring about a paradigm shift in breast cancer screening, and to do that, we need the voices of all of these stakeholders at the table. I'll be focusing this presentation specifically on payers and on self-insured employers, not only because we need to work with those partners to recruit the people we need to recruit, but also because working with them helps us not only cover the cost of the clinical services in the study, but also helps us establish the infrastructure such that that cost can be covered at the conclusion of the study as well. Athena has taken an innovative approach to working with these payers and stakeholders, and that's for a few reasons. The first of which is a funding reason. The study is funded by PCORI, the Patient-Centered Outcomes Research Institute, and one of the stipulations of that funding is that it cannot be used to fund the costs of clinical services. Another requirement is that the study puts in place now the infrastructure to disseminate the results at the end of the study, and that's the reason why we're doing the work upfront to establish insurance coverage. Finally, although we are billing for these clinical services, we can't use the normal medical center billing process, and that's because the clinical services in the study are covered services, but they're being implemented in an innovative way, and the genetic testing in particular is considered investigational on a population base, And we are giving a genetic test to everybody in the risk-based arm, and that is 50,000 people who will be getting that test. That's absolutely a population-based use of that testing. When we partner with insurers, we ask them to cover the 4 clinical services in this study. The first is an initial risk assessment to help us determine what risk a participant is at. The second is a follow-up risk assessment, which a participant will complete every subsequent year that they're in this 5-year study. And that's to ascertain if any risk factors have changed. If, for example, you enrolled in the study, but then in your 2nd year in the study, your sister was diagnosed with breast cancer, that will affect your risk. The third is genetic testing, which, as mentioned before, will be given to everybody in the risk-based arm. And the fourth is a breast health specialist consultation. And this is a consultation with a genetic counselor, and it's for those participants who are found to be at elevated risk. The model that Athena has established, it's required many steps, and the first of which was establishing Athena as an entity, as a unique entity, under the University of California Office of the President, and specifically under the Center for Health Quality and Innovation. What this has involved is the creation of a tax ID. And the tax ID is what Athena needs to submit the billing claims. Because, again, we're not billing through UCSF or UCLA or UC San Diego, Athena needs to have its own tax ID. We're also working within a coverage with evidence development framework. And this is it's a policy that has been used by Medicare and in some other smaller instances in the past. And what it does is it allows insurers to rapidly evaluate high potential value enhancing clinical innovations. This is a way, in other words, for a group, in this case an insurance company, to cover a service while still doing the evaluation of it, as opposed to waiting on a coverage decision until after the evaluation has occurred. Finally, we've been working very hard to define our end-to-end billing workflow. This is, how does the Wisdom study generate bills? How are those bills sent on to a third-party claims clearinghouse? How that clearinghouse then sends the bills to other payers, and then how the funds from those insurers comes back through the clearinghouse to Athena. We, just in April, signed a contract with Blue Shield of California, which is the first payer that we brought on board under this model, and that included an enormous amount of work. We established the clinical codes that we would bill under, we laid out the reimbursement rates, we determined the covered beneficiaries and the enrollment strategies, and it involved a lot of work on Blue Shield's end as well. They had to actually edit their medical policy in order to include coverage with evidence development. So this is it's a time-intensive and a labor-intensive process. For that reason, in our work going forward and trying to bring other payers on board, we've been partnering with the University of California Office of the President. And that office has helped us incorporate Wisdom into the new contracts that UC creates with insurers. And so the University of California as a system has a contract with Blue Shield, it has a contract with Aetna, it has a contract with Blue Cross, and Wisdom is being written into some of those contracts going forward, such that those services will be covered under those contracts. This results in different models for different insurers, but nonetheless it's a more efficient way to reach the same aim. And so this approach here is successful in covering what's called the fully insured beneficiaries of a medical policy. So if you have Blue Shield coverage and you have a PPO plan or an HMO plan or some plan where you're getting your insurance directly through Blue Shield, you'd be covered. But a lot of people get their insurance through their employer. And it's not only that it's through their employer, but it's through what's called a self-insured employer. And a self-insured employer is an employer that has worked with an insurance company to create its own health plan to offer its own package of benefits. So to clarify, you could get your insurance through your employer, but your employer would just offer the package, the Blue Shield package or the Health Net package that those companies standardly offer. Self-insured employers have specifically worked to create their own benefits packages. And so in order to cover those members, we need to form contracts and partnerships with some of these self-insured employers. So an example is Genentech. Genentech offers insurance to its employees through United, and they've crafted a specific benefits package. And so we've been working with Genentech to...
Raymond Benson, please report to C017. Raymond Benson, please report to C017.
So we've been working with Genentech to offer this package of services to their employees through crafting that United Genentech health plan.
This offers significant benefits to both the employer and the employees. The employer is able to offer what is, for them, a very attractive benefits package that in both the health and wellness sphere, and a lot of employers are becoming more interested in offering personalized medicine and genetic testing in general to their employees. It's also cost effective. The study services, as a package, cost about what a mammogram costs, and most people in the risk-based screening arm will be recommended to receive fewer mammograms than women who follow a standard annual screening approach. So this is both an attractive and cost-effective offering for an employer. For employees, it's also engaging in that employees get to participate in this cutting-edge research. They get to learn more about their own risk, and they can help inform the science for future generations. So these are the two prongs. The previous slide is the approach where we've been working directly with insurers. This is the approach where we've been working with the self-insured employers. And these two together are helping us recruit the people we need to recruit and make sure the services are covered. So I'll end by returning to this paradigm shift slide and talk about how all of the work we're doing now really is with an eye towards dissemination. So for most clinical trials, at the end of the study, results are published, and there's still that 2 to 5 year lag, sometimes more, between publication and implementation of any applicable findings. The work that we're doing and the work that PCORI is helping us do is to make sure that dissemination is possible as soon as the study is done. If personalized screening is found to be more effective, we will have set up all the infrastructure for it to be put into place the next day. And our work with all of these people helps facilitate that. We need participants and patient advocates to work with us to be invested in the study and in the methodologies. PCORI has helped fund the study. The technology partners have helped us put into place the infrastructure. Payers and self-insured employers have made sure that we can cover these services. And we work closely with policymakers and scientific bodies, both to make sure that all of our recommendations are within national guidelines and to make sure that we can feed back our findings to inform future iterations of those recommendations. So I'll end with acknowledgements and ask if there are any questions.
How about ending with what you learned this year?
Yes. I could do that as well, now that I have my extra minutes. So I'd say the two main things I've learned this year, the first related directly to wisdom, is that wisdom, and the payer piece is such a small piece of this, but the wisdom is this kind of massive, ambitious project where we are really, the metaphor is you're building the plane as you're flying it, and we're doing that. We're trying to create all these new systems, all of these new mechanisms on all of these different fronts. And I think one of the things that I've learned in being involved in this project is how to look at that picture, how to think really with Laura's guidance about how do you see what this should look like and how do you keep that in mind, and then also how to drive forward the little details and how do you not get lost in the weeds and how do you not think, oh gosh, this is hopeless, we're trying to do so much, and it's how to hold those two in balance at the same time. The other thing I'd say, and that I want to include, is that the work with the Patient Support Corps has been really the highlight of my time here. And I think it's not only been sort of the privilege of working with patients and being able to contribute in a tangible way to their care in a way that pre-professional people aren't usually able to do. Usually when you shadow, the benefit is to you, really. You're not able to contribute to the patients, and being able to generate these question lists and these recordings is amazing. And it's the ability to learning how these protocols help patients not only articulate their own concerns and questions and thoughts, but help them articulate them to their providers as well. And having a protocol to help somebody work through the things that are swirling around in their head has been a powerful tool to learn. So I'm grateful for that.
Thank you. Thank you, Jeff. So I would say, why, we probably didn't, to be honest, we didn't have to do it with the insurance companies, buy-in. There could have been another way to do it.
Now you tell us.
Well, we're committed now. It's over. But so why? So obviously, I've made this a cornerstone of what we do. How many people get grants to do these kinds of things? Is this a common thing? Is this kind of change common? This kind of ability to improve the system common?
That's why that's what I've been so excited about the insurance piece, is that we're trying to, change the system with the money in the system. And I think that's when I first started, I thought, can't we just apply for some grants? Can't we just, ask somebody for some money and cover this and not have to build this entire billing infrastructure, which we're not equipped to do? And instead, in learning to do that and becoming equipped to do that, it facilitates system change.
That's exactly right. I'm hiring her. Okay, so, but that is exactly right. So that gave me an idea for tomorrow, for really, newsflash, we got to get this slide organized for tomorrow. But the idea, if you think about in industry, and I think the idea that I had about this is in industry, most innovative companies spend 10 to 20% of their revenues on innovation and coming up with innovative products. I think that's the benchmark. So what do we do in medicine? This is like a how many $1 trillion care industry. How much of our resources are going into innovation and improvement? I leave you with that. And so if you don't make this kind of change, we're doomed to have just the elites make it kind of spitting in the wind of how we change healthcare. This is a game changer, potentially. We haven't exactly pulled it off, but we're close. And if we can do that, you open up a gateway to saying, wow, we can really make a sea change. And don't think I'm not thinking about that for iSpy or all these things. Why is it that in cancer care we do the same thing over and over and over again as if somehow we expect there's going to be a different result? And yes, the NCI is funding it, but they are not, the amount that they're putting in is nowhere near that 10 to 20% of total revenues. So that to me is what, if we want to be an innovative profession, that should be our benchmark. And how are we going to get there?
So, good morning, everyone. My name is April Liang, and today I will be telling you about my project this year called OneSource. So, OneSource is an electronic data capture platform that we are building to address the data crisis that exists in medicine today. And today I want to tell you about everything that we've learned and achieved this year. First, I want to go through some of the challenges of data unification and building the OneSource system. Next, I want to tell you why we believe OneSource is really worth all that effort and can be the way of the future in medicine. And lastly, I want to share with you some of our achievements this year and tell you about some of the ideas that we have in the pipeline as well. So, to get started, by show of hands, how many of you are using Epic on a daily basis for your work? Okay, keep your hands up, but how many of you feel like you're spending too much time or effort finding data you need in the EHR? All the hands stayed up. And the reason for that is when we moved from paper charts to electronic health records, or EHRs, things really didn't improve that much. They didn't really fill in their promise of, giving us all that computational power. And that's because EHRs weren't built to leverage all the power that the electronic medium can provide. Instead, OneSource is built with that design to harness all that power that computation can give us. So what is OneSource? So the goal of OneSource is to capture clinically relevant data once in a structured format at the source, and then enable that data to be reused in a variety of settings later. And the way we achieve this is OneSource can receive data directly from the EHR and the patient. We will also be providing doctors with electronic checklists that they can complete either in the EHR or on their mobile devices. And these checklists are basically a series of simple questions about their patient's breast cancer. For example, what is the ER status? And the responses to those questions are saved in OneSource. And later, should that patient enroll in a trial or join a registry, OneSource can automatically send that data to those systems, because OneSource speaks a common language, a standard language, as those systems. And that way, data can be streamlined between clinic and research. But in building OneSource in the past year, in building and designing it, we encountered some challenges. in 3 overarching areas, and those were regulatory, technical, and operational. For example, in thinking about regulating the one-source system, we had to ask, who owns the data in the one-source system? And for that matter, who owns the system itself? And in addition, what is the legal status of OneSource in relation to the EHR, which is the legally recognized system of record? The technical issues, on the other hand, arose mainly from UCSF having several distinct electronic clinical systems. So in addition to the Epic EHR that so many of you use, the pathology department has its own system called CoPath. Radiology uses a separate system, MagView. And because OneSource needs to be able to talk to all these different systems, many integrations are needed, which increases complexity. In addition, each of these systems has its own IT team. This means that the human collaboration aspect is also infinitely more complex, as we need to coordinate with all these different people. And finally, the last area of challenge is the operational challenge. As Laura said in the beginning of this presentation, change is challenging. And I've found that medical field in particular can be hesitant to change. You know, workflows, routines, habits, they're all already established. So in order for OneSource to be really adopted and used and welcomed by users, it has to be both rewarding and respectful while being revolutionary. So after talking so much about challenges, it may seem like OneSource is an unattainable goal. But I believe that OneSource is not just possible, it's also integral and invaluable to the future of healthcare. OneSource is a solution that really benefits everyone. So for physicians and clinical staff, OneSource can dramatically improve accessibility and clarity of data. So you will literally have at your fingertips concise and critical data elements for your use at any time. The collaborative model of OneSource also means that data is more up-to-date and accurate. Finally, we will provide real-time reporting and visualizations of data that can support your clinical decision-making. For researchers in biopharma, on the other hand, OneSource will eliminate a lot of transcription errors and cut down on the need for source data verification. This dramatically reduces the cost and time of operating a clinical trial. It also can increase trial enrollment because trial eligibility matching can be more clear and transparent. Lastly, with the rich data in the OneSource database, trial managers can run in silico studies and pretrial feasibility studies to determine if a trial is even worth pursuing before spending all that money into running a trial. But in the healthcare industry, everything we do ultimately has to benefit the patient. So patients will benefit indirectly from all the improvements we've provided to physicians and researchers, but also more directly. Patients will no longer be asked the same questions over and over and over again when they come into clinic, because all the data that really needs to be known is in one place. By giving patients more direct input into their own health information, we give them a safer and better patient experience. Finally, continuity of care becomes more seamless with the OneSource database. So I hope I've convinced you that the OneSource system is really worth overcoming those challenges we've discussed, and the way that we can bring our electronic medical records into the 21st century, which is what we deserve. And so last, I'm very proud to be sharing some of the accomplishments and some of our future ideas that we have. So we've already made a lot of progress this year. We have 2 projects that are happening concurrently. So the first is the iSpy RCB pilot project, where we will allow iSpy pathologists to input data related to residual cancer burden, RCB, directly into the iSpy database, rather than have study coordinators manually transcribe it.
And we're in the final development stages of that already. The other project we're working on is the clinical care checklist for the breast care center. And since a picture is worth 1,000 words, I want to show you what we envision that process to look like. So these will be the checklists that are embedded and integrated into the Epic system that physicians can use to have a seamless one-source experience. So those of you familiar with Epic, you can tell this is what Epic kind of looks like. So here, you might notice something new and different. This is the one-source checklist box that we hope to create. And what will happen is, for example, Carrie, the nurse navigator, will talk to patients first, and she can just kick off the process rather than having a surgeon do all the work. So she can, oopsies. So she can input some information on a new patient coming in while she's on the phone with them, trying to learn about their situation. And she learns all these details about the patient's background and initial diagnosis, but right now she puts them in an email and sends them to the doctors. Here, in OneSource, she can put that information in this checklist. For example, the screening mammogram was the method of detection, and input all this information about the patient's disease that she's learned while she's on the phone with them. She does everything that she can and leaves the rest to the doctor that comes next. So she'll just save that. And you can see that it's laid out in a clear and concise format after she inputs it. So then when Dr. Esterman comes along and sees the patient, she can just review what Carrie has already done and notice that, oh, I need to perform that clinical exam. So then she just clicks here and puts in her observations from the clinical exam. For example, yes, there were palpable nodes. And then that's there in the system. And because, like everyone else, physicians hate doing duplicate work or more work than they need to, OneSource is integrated seamlessly with Epic so that by just typing in a shortcut, for example, the patient history, you can load that into a clinical note. And that will save on a lot of work. And finally, another great innovation we have is this patient at a glance longitudinal record. It's an interactive timeline of all the most important events that this patient has undergone. For example, a biopsy and then the results, as well as chemotherapy. And these can be exported into a treatment care summary, just like that. So that was a preview of what we want OneSource to look like when it's in Epic. So our future work, there are numerous applications for OneSource, and only a small selection is listed here. And one thing that already came up is that we want to interact directly and reach out to patients directly so that they can engage in their own health information and record. So to give you a glimpse of an example is one that we've already discussed, which is the iSpy quality of life. So you saw the paper surveys that we were using and how things aren't very well integrated or accessible to patients and facilitate data collection. So what that process might look like with OneSource is we can have an email sent directly to the patient on their phone. They can start that survey right on their mobile application and tell us about their distress level and their fear and their trouble with heavy shopping bags. So they can just go through, and if they lost a lot of hair, they will be asked automatically about how their feelings were regarding that hair loss. And once they submit, what that means for the trial management team then is these wonderful dashboards where you can see exactly which arms in my trial had contributed most to fear or I guess hair loss or physical limitations. And you can also drill down into a specific record to see longitudinally how did that patient feel across 6 months of their treatment. So in conclusion, OneSource, there are a lot of challenges to making OneSource a reality,
but we really believe that it's worth that effort and it will change the future of medicine. So I'd like to ask you to support us in this revolutionary endeavor that we're undertaking. Thank you.
A true acolyte there. My work here is done. Okay, so if everyone can just take on this mantle and work on implementing that. I obviously, I think this is like incredibly exciting. This is the vision of the way care should be delivered, and it's the way the day-to-day care. I think it changes the jobs of physicians to be, interpreters of information and actively engaged, not in the incredibly annoying things of documentation, which are our current life in Apex or Epic, but it really in this business of being able to engage with data, engage with patients, engage with, the idea of making things better. That should be our job. Our job should be practice to improvement and practice to improve what we do, not just do what we do. April, what do you think, now that we have kind of the vision and the pieces and the tools, let's just say all the tools are ready tomorrow, what do you think is going to be the biggest challenge in getting them to be successfully implemented? What do you think that's going to be?
So when the tools are ready, I touched on this, but convincing people to change their habits and their mindsets and really adopting this tool and seeing the benefits of it. And I think that's part of our job as designers and builders, which is to make this tool as easy to use and intuitive and as beneficial as possible. So I know disruption is like a super hot word in tech nowadays, but we want disruption that isn't disruptive.
Right.
for the clinic, right.
Well said. Thank you. Any other questions? By the way, doesn't everybody want this? My I Spy people in the back, aren't you so excited about this? We could have this? Would that be so amazing if every I Spy site used this and this would be your dashboard? Wouldn't that be just unbelievable?
I think dashboard would be exciting.
Aspire to better, the iPhone 8. And Allison, this is...
My one question was going to be how you thought this would improve the safety of patients, which was so
Great.
value add, but I think that the example that you gave of the iSpy dashboard is a perfect example of being patient's
Right.
experience. So.
And what I couldn't show of that is we have this idea too of automated clinical triggers. So if someone reports having very bad side effects like diarrhea or something that is more acute, then it can trigger an immediate message to the clinical care team that can lead to a phone call or some sort of resolution of that side effect, because that is something that that knowledge should enable something rather than just being a piece of data.
And that's actually the insight I get when I was sitting in the Dreamforce presentations. I was like, why, people are coming in, like one of the drugs we had in iSpy caused a lot of diarrhea, and we find that we had to, like I was having, I said, we have to call every patient to make sure they're taking their medication the next day and be proactive, because we had no idea who was doing it or not. I'm thinking, wow, if they know whether or not they're selling enough wine, someone can get a message and call. For God's sakes, we ought to be able to have something that's a matter of life and death, or like real patient safety. All those things could be automated, it should be seamless. There's just no reason not to have it work out that way. So, awesome.
Thank
It's
you.
great. And again, if we make these tools, if we make the tools easy to use, that people want to use them,
They will come to us.
that's right. Exactly. All right, Rebecca, you're up. Oh, wait a second. Oh, did you say what you got most?
Oh, no, I forgot.
Aha.
I think one of my most big takeaways is just the opportunity to have worked on something so innovative and cutting edge, and being a part of that, part of something that I think could really change the way that medicine is practiced. And it's something that I believed in before I came here, so having this opportunity to find a kindred spirit in Laura and having her recognize something in me and letting me on the project, that has been really wonderful. And the practical aspect that I take away is definitely navigating the work environment, so work politics and managing up and interacting with colleagues and supervisors, taking criticism and learning from that. So that's been really rewarding. So thank you.
Thanks. All right, Rebecca, now you're on.
Okay, I can start off by doing what I've learned. I was planning to include it in my thank you, but I figured now is also an appropriate time. So when I was making this presentation, I was thinking about something that Cindy Perlis, who directs the Art for Recovery program, told me a while ago when she was speaking to us. So Cindy got her start working with AIDS patients, and so she saw a lot of death, a lot of people pass through her lives. And she told me, and a group of us actually, that one of the things she did to sort of help herself cope with this and to really acknowledge the impact of all these people passing through her lives was just to write down their name and then just a sentence about how they impacted her life and how it felt to have them sort of pass through her life and to be a small part of it. And so I was making this presentation, I was talking about how many patients have died, how many patients have chemo, percentages and stuff like that. And then I was thinking about Cindy, and I was realizing that every one of these numbers is really someone that I've spoken to and I've talked to, that I've known in some way. Some of them I've known for a couple years. I followed them over the course. And so I was thinking, so the thing I've learned that I hope to take with me is related to Monta's comment about humanity, that while we need this data, and sometimes it's a pain to collect it, hopefully not, every sort of data point represents someone's life and individual story. And that's something I hope to take with me as I move into, hopefully, palliative care. So my name is Rebecca, and today I'm going to be talking to you about some work I've done about an integrated palliative care clinic and looking at end-of-life outcomes and referral patterns amongst this palliative care clinic, thinking about the idea of getting patients the right care at the right time for where they are in their disease course, and sort of targeting our discussions to really where they are and thinking about sort of their issues at hand. So these were my projects this year, and I wanted to start off by actually saying thank you to Ekne, who's here, who in 2012 was a former intern who really made a lot of this work possible when this effort was kickstarted. And so I've been looking at her great manuals for years, so it was great to put a face to the name. So my primary project this year was the ABC, or Advanced Breast Cancer Program, and that the big idea of this, which Laura started off a couple of years ago, was to address the unmet needs of stage 4 patients here that people experience as a result of living with incurable illness. There's just a lot of different kind of stresses and symptom burdens that I think is very different from the early stage setting. And so one of the things we did to address this was work on integrating a palliative care provider into the breast oncology clinic, really with this idea of providing concurrent care. And so I'm going to start off my presentation by defining some terms that I'm going to use often in the next few minutes, and then I'm going to talk about our results and then next steps. So first, since this is going to be all about palliative care, I wanted to really work on defining palliative care. As Mamta mentioned, there's often a lot of misconceptions about what palliative care is, specifically with its relationship to end of life and perhaps some negative associations about giving up. And so I put the official definition for the Center to Advance Palliative Care up here, and it is specialized medical care for people with serious illness. It is focused on providing patients with relief from the symptoms, pain, and stress of a serious illness, whatever the diagnosis. The goal is to improve quality of life for both the patient and the family. It's appropriate at any age and any stage in a serious illness, and can be provided along with curative treatment. So I really wanted to stress that it's appropriate at any stage in a serious illness and can be provided alongside with curative treatment. It doesn't mean that you've stopped trying to do chemo or anything like that. It just means you're getting some sort of extra support about dealing with the complexity of a disease. And so it is for any serious illness. In this case, I'm obviously talking about palliative care in the context of cancer. And so at UCSF, the symptom management service provides outpatient palliative care. And specifically, I worked with Dr. Mike Rabo, who's the director, on the development of this integrated clinic. So I also wanted to define the term hospice, because I'm going to use it in my presentation as well. So hospice is a type of palliative care, but it's not all palliative care. Hospice palliative care is specifically provided, Mamta referenced this in her presentation as well, when curative treatments are no longer beneficial or when patients are entering the last weeks to months of life. Usually it's sort of recommended when there's around a 6-month prognosis or less, is the idea. And so these services are mostly provided at home for home services and visits, but there are some residential facilities, though receiving care at home is much more common. And so I put this graph up here because it represents sort of palliative care as an umbrella term, and really when is it useful and when should we be using it. So you'll see here that if you're looking at a patient's trajectory, palliative care is really provided alongside this traditional oncologic care, which can be curative, life-prolonging, or palliative, meaning that sometimes meaning that a lot of the oncologic care we're providing in the metastatic setting can actually help palliate symptoms. For example, perhaps your chemo is treating the cancer that's giving you these symptoms. And then I also want to point out the little spikes in this graph. So perhaps these represent instances when palliative care is going to be called upon to provide extra support. For example, if there's a progression, the patient is anxious, talking to a palliative care provider can be useful. There's a new treatment, there are new symptoms, palliative care can be particularly useful in that instance. And then the other thing is just to note that, so when there's a 6-month prognosis around, and when curative oncologic care is really stopped, that's when something like hospice and focusing on palliative care only is employed. So I showed that nice little graph, but why did we think that? Well, it turns out there's a lot of evidence for an established benefit of early palliative care that's provided alongside oncologic care. So sort of the big, I guess, recommendation came from this ASCO clinical opinion in 2012. So ASCO, American Society of Clinical Oncology, they're the big guys here, said that combined standard oncology care and palliative care should be considered early on in the course of any illness for any patient with metastatic cancer and or high symptom burden. So why did they say this? Because there's a lot of data that palliative care provides better quality of life and better mood for both patients and their caregivers. And people also received less invasive treatments when they were getting palliative care, which makes sense. They're sort of talking about what's going on, what's important to them, what kinds of treatments they might or might not want to receive. I also wanted to point out a recent paper done by 2 UCSF doctors looking specifically at early versus late palliative care at UCSF in our own cancer center. So they looked at the UCSF Cancer Registry across all cancer types, and they compared 2 arms. Early palliative care, which means that the patient was referred to palliative care with more than 90 days prior to death, versus late palliative care, which is less than 90 days to death. And they found that early palliative care is associated with less intensive medical care, improved quality outcomes, and even cost savings at the end of life. So, given all this data, we wanted to implement this here in our practice. And as I mentioned, we decided to do this through the ABC, or Advanced Breast Cancer Clinic here at UCSF, leveraging an embedded physician, Dr. Rabo, and a care coordinator, which is me. And so the way that this works is that we have co-location in the oncology clinic, and the oncologists or other providers, but largely the oncologists, refer patients to see palliative care. And in these appointments, the physician addresses management of symptoms, but symptoms broadly defined, they could be physical, like pain, fatigue, nausea, or they could be some of the more emotional stresses and concerns that come along with living with incurable disease, anxiety, depression, thinking about the end of life, things like that. Another thing we strive to do is to really discuss life goals in the context of a metastatic breast cancer diagnosis. What are some of the things you hope for? What are some of the things that are important to you? How do we put that into play? And also, as is a theme that's been running through today, providing some education with regards to treatment decision making. Sort of what have people heard about the benefits or possible consequences of this treatment? How are they thinking about that in terms of their own life? And how can we support around that? And we really want to provide this both during this oncologic care period when people are being treated for their cancer, and also when people are nearing the end of life. So if you're nearing the end of life, your treatment decisions might be more along the lines of what kind of care you do and do not want to receive, things like artificial nutrition, thinking about where you want to die. And also designating a medical decision maker in the case that an individual cannot speak for themselves. So now, I know I'm running out of time, I want to get to the clinic results. So we've had about 18 months of this integrated palliative care clinic, and we decided to look at the patients who have died during this time period, so we can look at their trajectory. And so Amongst the 108 people who were referred, 38 are now deceased. And so amongst these people, we wanted to look at program participation, so who are we reaching, referral patterns, so who's being referred, when in their disease, and why, and then finally, end-of-life quality outcomes. So when we looked at program participation, as you can see here, we noticed that not everyone, though I've just talked about how great palliative care is, not everyone was actually seen. We saw 23 out of 38 patients at least once, with an average of 2.9 visits, with a pretty big range. And of the 15 unseen patients, I have the reasons up here for why they weren't seen. So we wanted to see, why aren't we reaching these people? So 6 initiated hospice before they could be seen, and 5 initially declined because they just didn't want to deal with it, or et cetera, and then they became too sick to actually take advantage of this service. And then 4 reported not wanting extra appointments or just didn't respond to repeated follow-up. We also wanted to look at why the oncologists thought this would be beneficial for their patients. So what was the goal of the referrals? And I did this by chart review. So 40% of people were referred for symptom management, but as you can see, a lot of people were also being referred more just sort of for support and coping with this kind of illness. And some as well, 3 out of 38 for just really early on dealing with kind of the impact of a new metastatic diagnosis, really to sort of orient to a kind of support that's available through palliative care. So next, we wanted to try to collect some information that would be useful for the palliative care physician to get sort of a snapshot of where these patients are in their disease course, so that he can figure out, what's appropriate to talk about now, what subjects might I want to raise, sort of what does sort of the landscape look like. And so we talked to the oncologists who are the experts in this, and there's a lot of variation in prognosis with people who have metastatic breast cancer. Sometimes it can be very, very aggressive disease that can cause someone to die within a couple years of diagnosis. Sometimes patients can live for many, many years with a pretty good quality of life. So we really wanted to try to capture sort of things we could look at to kind of orient ourselves to what someone could expect. So here are some of the things that we looked at. We looked at biomarker status, because there are a lot of treatments that are targeted towards patients who are hormone receptor positive. It's also can be generally less aggressive disease. With HER2 positive patients, a lot of it is being more aggressive, but again, there are treatment options that are tailored. And then with triple negative breast cancer, a lot of it is being more aggressive, and there also we just don't have targeted treatment. So that's kind of like a prognostic snapshot. We also looked at things like time since metastatic diagnosis. How long has someone been living with this? The number of disease sites they have and where. Looked at their age. And then over here, we also wanted to think about how many lines of treatment someone has had, just really to get an idea of sort of what they've experienced and what they might in the future. So we broke it down into categories of having not received any treatment yet for the metastatic disease, so very, very early, having received hormone therapy only, first line of chemo, second line of chemo, and third. So you can see here, we actually received a lot of referrals for people who had had multiple lines of chemo already, implying that they had, seen a fair amount of treatment for their disease, maybe were a little further on in their disease course. And then lastly, we of course wanted to look at end-of-life quality outcomes, what ended up happening to people, and how did their sort of end-of-life patterns compare to national quality standards. So it turns out that we had 24 out of 38 deceased patients who qualified as early palliative care referrals. They were referred with greater than 90 days prior to death. And so comparatively, using that cancer registry data, in the year prior to ABC, only 25% of breast cancer patients who received any kind of palliative care actually received it early. So we saw that we are actually reaching people a bit earlier. And so here, we're looking at patients who have a confirmed date of death and who we have information about their care leading up to the date of death. So as April was saying, sometimes finding data in the EMR can be a little bit of a fishing expedition, which I found out as I tried to compile this. So our number dwindled a bit to patients who we could really report on for what happened to them in the period leading up to their death. And so these are some quality measures that we saw in our patients. So having chemotherapy in the last 2 weeks of life is usually considered a bad quality outcome. It means you're getting pretty intensive treatment right up to the end. And so we only saw, so of the people that we saw, only 5 people out of the 18 that we have information received chemotherapy in these last 2 weeks of life. We also had no one in the ICU in the last 30 days of life, which is also a bad quality outcome. And as you can see, 13 out of 18 of these people utilized hospice, which is a really good quality outcome. And of these people, only 1 out of 13 use hospice for less than 3 days. And that's considered sort of a bad sign that you're not spending enough time in hospice, that you're really pushing for treatment right up until the end. So discussion and next steps. So we found that ultimately this embedded practice did result in breast patients being seen earlier. And we want to direct our future efforts at increasing these earlier referrals. As we saw, we did have kind of some range of where people were in terms of their treatment course. And also to facilitate patient acceptance of early referrals. As I mentioned, not everyone accepted these services, and we weren't able to reach everyone who was recommended for this kind of care. And so forthcoming next year, because I'm actually working part-time with Mike Ravo to continue some of this work next year, is going to be a coverage with evidence development project with Blue Shield using this ABC model. So we have a very small number of deceased patients who did have Blue Shield coverage, but with those patients, we hope to really give them some information on sort of, for the patients we did see, what were some of the costs associated with that, what were some of the outcomes, and how does that compare to people we didn't see, and ultimately, how would that benefit Blue Shield, so they want to help us. And then we're hoping that this is a model that can be expanded. So that's all the time I have for today, and just wanted to say thank you for everyone involved in this project. A huge thanks to Mike and Jeff, my mentors, for Tia and Shelley for supporting me at Laurel Heights, and to all the oncologists who referred patients, and of course the patients and families who I was able to meet during this project. I think in many ways they're our best teachers when we learn about this kind of work. And yes, thank you.
One of the things, don't forget in the Blue Shield, you don't have to just look at the Blue Shield patients. That's not necessary. They actually have a dedicated, I've been talking to both. Are you going to be there tomorrow? Okay, because Marcus Thuggis is going to be there tomorrow. Sunday? That one of I hope that people can see that, the model that we've developed in Athena is the model, is the prototype. So the idea is that each time we build one of these models, it's complicated, but the next time you use it, it's easier. I think this is actually a really interesting exercise. Ekene started this project when she was, it was some cockamamie thing. It was 50% of your time, and where we're going to make this work. But I think you can see, isn't it impressive how much has happened? These hard projects you have to keep at, and I'm grateful to Jeff for stepping in at the beginning to really mentor this and move this along. But I think this has now developed a life of its own, and talk to you about how to take those outcomes and change it. This is an easy thing for us to move across the UC systems. And I think you can move things horizontally, you can move things vertically, but this is, again, this model is, how do we take the resources in the system and repurpose them in such a way that we bring better care to people? And it's one of the things that we're focusing on tomorrow in our talking. But again, this is from across the spectrum, from prevention all the way to end-of-life care. And hopefully documenting just the different kinds of conversations you can have at the end-of-life care, where instead of just doing the same old thing, maybe you do a trial, or maybe you do something that is less intensive because the quality of life is better. Jeff, you had a question?
Well, maybe a statement and a question. I mean, I remember when we started this, I can't remember, when we were rolling it out, it might have been with Ekene, it might have been with Jenna, my vision for this
Jenna was before you, right?
No, after.
After, okay.
Before me.
Ekene was the first, yeah.
And my vision for this was that we would liken patient support corps, we would simply have an intern call every patient who had a new metastatic diagnosis. And
I still think that's a good thing to do.
yeah, well, so the pushback, and I still don't understand the pushback fully, but there's a gatekeeping concept in healthcare with between physicians and patients, and whose patient is it? And I think the medical oncology team was concerned that patients were in a vulnerable condition, and having an intern call them and offer SMS, palliative care, ABC services just might not go over very well and might backfire or something. So that at the beginning didn't seem like it was going to fly. So we backed off of that, and instead the medical oncology team has been referring patients. I think we're starting to see more and more referrals. So the question is, I guess, is it time to go back to that idea?
Yeah.
And does Mike, do you and the team have the capacity where if really every patient, if this was just routine, then the number of patients receiving early palliative care would be 100%, or at least they would be offered it. And maybe they would decline it, so it would be 100%, it would be 80%, 70%.
Right, absolutely, yeah. I think that, so we would probably have to go more specifically into our numbers about really just looking at those clinic slots and who's referred in sort of a denominator for patients. My impression is that we don't quite have the resources because it's, at the moment, is really just sort of Mike and I. So I think also the thing with kind of offering it to everyone is then in the case that we can't really deliver on that care for everyone we've offered it to, that becomes an issue. And I think it is totally an issue because there's a lot of data that this can really benefit anyone, but then we also have to consider, do we have the resources at the end of the day to make that offering?
How about this? Why don't you talk to Mike, I'll talk to Mike. We'll talk to him tomorrow. But let's imagine a year from now that this is a funded program, and we're thinking, so tomorrow morning, when I interview Alan Entov, one of the things he's going to talk about is why we need to be in the mode of integrated healthcare delivery systems. This is not a personal physician issue. This is a quality of life issue for patients. It's an opportunity that everybody should have, regardless of what physician is taking care of them. This is like I don't ask people if they want to see a surgical nurse before they go to the operating room. I create a program so everyone gets that opportunity for education. And why do I do it? I make up for the variation in physician practice to make sure, and because we don't want to necessarily go into that detail. That's okay. So you make up for it by that's what systems do. Systems help make sure that everyone in your program or everyone associated with your care get the kind of quality of care that they deserve. Not because it's an accident of who they happen to see. That's a cottage industry model, and that's the difference. So we can aspire to better. Okay, so to get the pilot up, we did things the way we have to. But when we go to implement this, we need to be thinking about this in a different context. And I think this should be part of what we want to implement. And we should be doing this across Athena, and I'm going to put it on our, in our sort of package of services for this, CALM model, the accelerated learning model, because this is soup to nuts, prevention to end of life, that we're trying to create a different model.
Yeah,
go ahead.
Oh, I just had a quick comment. And I should say that we are getting a little bit more capacity. Mike recognizes this, but I think his department, as many others, does have limited resources. But we are getting another ABC provider, and one of the things that Mike and I have talked about this year with some of the oncologists is really sort of using some criteria that I didn't talk about so much today to sort of target people who might be the most vulnerable to do some outreach.
Yeah. But I think this is the kind of data, and by the way, on that graph should be what you think, what the standards are from ASCO. What fraction of people worst to best average for end of life care? How many people are getting chemo at the end of life, et cetera. Add that to that table, and that's your data, right? But I think that we have to be bolder. If we want to make it's time to make these changes. Again, this is about taking back the profession and saying, how are we going to do what really needs to be done? It's not about us, honestly. It's about our patients.
Yeah, I was going to add kind of to what Jeff is saying. I think the concern I would have, right, is about timing. And I think that's the key thing. What is the right time to introduce SMS, right? Because I can imagine that the first time you get your metastatic diagnosis is not the time you're ready to talk about it. So like, how do we figure out along when do we start asking when we offer? Because I can imagine if you offer it too early, I shut down. If you offer it too late, I lose out. So how do we? That's I mean, that's the
We
question.
normalize it.
Exactly.
Yeah.
We
want to
normalize it. The University of California, all 5 medical, institutions that amongst us are the top institutions in the country, certainly the top public institutions, all feel this is a standard of care. This is normal. Every patient we see will get this kind of care. That's how you normalize it. That's how you change the expectation, you change the culture. That's the power
Yeah.
of having something at that scale, I think.
And we learned this in the patient support corps that we call all patients with appointments, and we say to them, we have materials and services that might be resources for your upcoming appointments. And it doesn't need to be, I don't think I have anything like I'm calling to talk to you about metastatic cancer.
Calling to talk to you about death. No,
but then I'm talking to you about materials and services that are available to you, and I'm just an intern, so it's not going to be like a.
It's not threatening at all. Hey, we just want to talk to you about additional services that are available. Make sure that you're aware of them. You can access them now. You can access them later.
Yeah,
So we absolutely are going to do this.
And Jeff did push very hard for this at the beginning, I remember.
Okay, now's the time, Jeff.
So I guess first I'll start off by saying what I've learned, and some of them have been taken, so I'm trying to say something that's different. I think something I've learned is what you can get done the more people you involve, so don't try and spearhead things necessarily on your own. You might find someone who has dealt with this and troubleshooted a problem beforehand that can kind of guide you in the right direction, or you might find someone else who's excited about something and can also help guide you in the right direction. So teamwork, finding other people who care about the same things you do can help get things done rather than going on alone. So, and along with loving community, etc., I agree, those are all important things. So I'm going to talk about, and some of this may be familiar to some of you, because I'm picking up where Tessa, a previous intern, left off, and this is Dr. Chen's project. So it's a retrospective chart review of fertility preservation practices within the I-SPY 2 trial and its effect on the time to initiate treatment. And I'm going to start off by going over the background. Why do we care about this? Why is it relevant? Talk a little bit about the study and the results that we've gotten, and then next steps. So first, background. About 10.7, so 11% of new breast cancer cases are in women under the age of 45. So there is a population here. We can't just ignore this 11%. And in fact, in I-SPY, it's 29% of our patients are under the age of 43. So, and why that is, maybe because we're a tertiary referral center, or younger women sometimes have more aggressive breast cancers, and neoadjuvant treatment is recommended for people with more aggressive breast cancers. That may be the difference in the numbers, but regardless, there is a young population, and it's something we need to pay attention to, particularly because people are waiting to have kids later, and this is especially true in college-educated populations. And the reason why this is important at all is that one of the drugs used in I-SPY, cyclophosphamide, is it impacts the ovarian reserve, so it affects or can affect your ability to have children later on. So we can't ignore it. It is a fact. Having a family and having children is important to some women, so how can we address this issue? So, as I said, how can we address these fertility concerns? So, controlled ovarian stimulation accompanied with cryopreservation is the most effective. I know that there are other options available, but this is the one that we focused on for the study. And then what are kind of the concerns with doing this? Obviously, what are the implications? What are the effects on oncologic outcomes? So we can't really say much, or there is data in the adjuvant setting that this ovarian stimulation and cryopreservation doesn't affect the oncologic outcome, and so in a way that it is safe. But in the neoadjuvant setting, what we're concerned about is, are we making the time that they have this intact tumor waiting to start treatment, are we extending that time and therefore putting them at, higher risk of it spreading? So we focused on the time to start as something that we wanted to avoid extending it, and are we actually able to, is it the same for those who harvest and those who do not? So primary objective, as I said, is we want to look at the time to start and whether there's a difference between those who go through cryopreservation and those who do not. And then secondary objective, we wanted to look at the characteristics, both patient demographics, tumor characteristics, to see, what are the differences between our two groups, and then follow their reproductive outcomes and oncologic outcomes. So methods, this is a CHR-approved retrospective chart review of our I-SPY 2 patients who were in screening from April 2010 to April 2016. And initially, we only had inclusion criteria to get all of the patients, to capture all of those patients. And they only had to be under the age of 43 and had to be screening and have signed the screening consent form between those dates. As we are going through the data and cleaning it, we realized that we actually really need to exclude some patients who were found to be metastatic, in which case you're not really receiving neoadjuvant treatment. And sometimes the workup can be extraordinarily long. Also, some patients decided during the screening process that they actually just wanted to have surgery first, and we had to exclude those. And then some were came, signed a screening consent, never had anything else done, and so we also excluded those patients. So originally, with just the inclusion criteria, there were 95, and once we excluded patients, we excluded 23 patients and had 72. So the data elements, I won't just read them off, all of them off, but all of the important stuff that we wanted to compare: patient demographics, gynecological history, the tumor characteristics, et cetera, as well as the oncologic and reproductive outcomes. So here's the data for the 72 patients who were under the age of 43 and screened for I-SPY and received some sort of neoadjuvant therapy. We did include those who received hormone therapy, and this was because they went through the entire screening process, were in the mindset that they were screening for a trial that has chemotherapy associated with it, and were in the mindset that there was a possibility they would be receiving chemotherapy. So although hormone therapy on its own doesn't impact ovarian reserve, Dr. Chen and I felt that it was appropriate to include these patients. So things to point out: the average age is 36 years old, so these are younger women. Many of them have not had children, and it's a predominantly Caucasian population. So differences in fertility consultation and cryopreservation. So of the 72 patients, a little over half consulted with a reproductive endocrinologist, and then of those 40, 31, so 77% actually went through with freezing eggs or embryos. So we thought that was a pretty high number given the concerns that patients might have going into it. So next, here it's split out. So again, in total, it's all of the 72 patients, but it's split out into those who did harvest. It's 31, as I said, went through with the egg harvest, and 41 did not. And we did some comparisons. So looking initially at age, there appears to be a difference, but it's not statistically significant. However, for number of births, we did find it to be statistically significant, which makes sense. You haven't finished your family, or you haven't had any kids. You want to keep this option open. It's just something that makes sense. And then clinical stage. Initially, we thought if you had a higher stage breast cancer that was more aggressive, it was larger, that there would be a concern that you wanted to start treatment right away. You didn't want to worry about doing fertility preservation, et cetera. And so we wanted to compare these two. And we actually did not find a difference, statistical difference between the different clinical stages within the two groups. So maybe for our patients, they just weren't thinking about it and they're focused on the reproductive outcomes. And then to our primary objective, the time to initiate treatment. So we did not find a statistical difference between those who did harvest and those who did not. So on average, it took 27 days from the time that they learned about I-SPY until the time that they started treatment. For them, that was 27 days, and on average. And for those who did not harvest their eggs, the average was 26.5. So as far as reproductive outcomes, as I said, this was our secondary objective, stuff that we just wanted to look at out of interest. So 15 of the 31 froze eggs, and no one has returned to use their eggs. However, with the embryos, 14 out of the 31 have returned, and actually one just delivered twins like a month ago, so that's kind of exciting, with the embryos that she froze before treatment. And there was really a variety for these 4 patients about when they came back to use them, some 4 years, some 3 years, some less than a year, and many used actually surrogates, so not, they didn't carry the child themselves, although the one who did deliver the twins did not use a surrogate. And we're still trying to get data for 2 patients who harvested outside of UCSF. So I put this up here, and Dr. Chen and I were debating if we wanted to include this just because we do not really feel that we can draw any conclusions from this, particularly the PCR data, but I did want to include it because we did look at it. And the reason I think you can't really draw anything from the PCR data is, although all these patients signed screening consent, not all of them went on to treatment consent, as well as some did hormone therapy instead of chemotherapy, etc. So what you can draw, what conclusions you can draw from this, I think are limited. But as I said, we looked at it, so I wanted to include it. So strengths of this study are that we have a relatively homogeneous patient population, given that we're kind of cutting off certain patients up front using the I-SPY 2 cohort. And a randomized trial will never be done to look at this because you can't really tell a woman, okay, you're gonna go through ovarian stimulation and freeze your eggs like this. So this is kind of the only way that we can address this question. And this is the first time really that we're looking at the neoadjuvant setting, and we have information in the adjuvant setting, but how can we assuage the fears of both patients and providers that maybe there will be, it'll take longer to start treatment. Limitations, so it's retrospective, the data isn't perfect. I mean, you have to search a lot for it and some of it is missing. This analysis can really only be applied to those who are screening in the context of a clinical trial. We don't know if outside of the context of a clinical trial, so in the community, we don't know how long it takes. We don't know if it's shorter or if it's longer. So this information can only be applied to those individuals who are screening for a trial. And as I said before about the PCR data, we really can't say anything definitively about the effects of ovarian stimulation and cryopreservation on the oncologic outcomes in terms of PCR rates or the effect that it can have outside of the time to start treatment. So next steps, MOMTA is working on some of this with Dr. Chen. So they want to prospectively collect all the data that I gathered and Tessa gathered retrospectively for women under the age of 43 screening for I-SPY at all sites, not just at UCSF, which that data presented is. And then also adding quality of life questions about fertility to better understand the attitudes surrounding fertility preservation. Dr. Chen and I are in the process of writing a manuscript to submit to a journal. Unfortunately, it's on pause because she had her baby on Monday. So she's actually on maternity leave. And consider adding retrospective data from other sites. We were talking about doing this a couple months ago, but as we talked to Mitch Rosen and some other people, it just didn't seem as feasible with the time that we had, but could be a possible next project since I won't be going far from here. So acknowledgements, obviously Dr. Chen and I spent a long time doing this, and Dr. Rosen, Dr. Letourneau, Tessa, who put in a lot of the upfront work, and obviously the whole BCC team that helped out and made this whole thing possible. So thank you.
Thank you. One of the things that really struck me about way back at the end, I also think it's interesting about what kind of result they have and whether they use their eggs. But I think way back when I first met Jeff, about 5 years ago, just kidding. One of the most insightful things I had was what I thought patients thought is not what patients thought. And that's why the consultation planning is so important. It doesn't matter how seasoned a clinician you are, your view is not their view. So I want to go back to that business of, that's what we thought about people with higher risk disease or higher stage disease wouldn't be interested in preserving their eggs. But it's probably not what patients think, right?
Yeah, well, given this information, it looks like no, that's not the factor.
Because, and that actually is consistent with clinical experience. When people are focused on wanting to have a child, it really doesn't matter. All those other things really don't matter. We've had patients with metastatic disease who want to do cryopreservation. So and the first thing is like, well, why would you want to do that? Or you can't do that. That is like one of the best ways you can take away hope from somebody. And, we just don't know what the outcomes or the length of times of these things are. And clinicians are often shocked that someone would rather have a child than go on to treatment X. But it's all perspective. Don't forget to give your either the beginning or the end.
Okay, thank you. I'll go over what I've learned, the lessons I've learned at the beginning. One of them, I have two today. One of them is don't be put off by the long timelines that you'll see on a lot of your projects. You'll think that something as easy as implementing a survey will actually take several months. But actually that ends up being a good thing because it gives you the opportunity to stop and think about, well, what are the things that we actually want to add? What are the things that we want to make sure we're doing right the first time so we don't have to recreate it later? Which leads me to my second point, which is as you're here in your year, interns, it's a really great idea to really absorb everything you can from your peers, from presentations you hear, because as you collect all of that, you'll see ways in which your work intersects with the work that other people are doing, and it really gives you an opportunity to merge what you're doing and hopefully create, or as you're working on your projects, it'll give you the opportunity to move your projects forward in a direction that's collaborative and not siloed.
Excellent. An excellent point, and that's part of the reason we do these presentations at the beginning, so people have that in mind going forward and how to create synergy, because it's all for the same common goal.
Yeah. So today I'm going to be talking about something that I've been working on for my 2 years here, which is the supportive care resources, how we make referrals to them, how patients use them, and what patients' preferences are for receiving them. And I'll give you a background on what supportive care needs means in the context of breast cancer, and I'll go over how we've gone about addressing those supportive care needs in the breast care center through the Athena Breast Health Network, and then I'll talk about a research survey that we sent out to several of our patients to try to get information on why patients aren't utilizing the resources that are available, and also what patients' preferences are for receiving them. And then I'll go over my future directions. I don't have a definition slide, but what we talk about when we think about supportive care needs are all of the things that affect a patient's quality of life and a patient's overall health that aren't directly their medical treatment from their oncologist or their surgeon. And as you can see, about 3 million women in the United States living with breast cancer, and beyond medical care, there are a lot of unmet quality of life things that affect quality of life that affect our patients. And that could be things like psychological and emotional distress, or lifestyle things. So there's really this big need that's been identified to provide patients with appropriate and also timely supportive care needs as they move not only through treatment, but also the phase of care that comes after treatment. So the Athena Breast Health Network, as you've heard a little bit about, is a collaboration between the 5 UC medical centers and also Sanford Health, which is a health system in the Midwest, in the Dakotas. And what we have leveraged with our system, and specifically what I'm talking about today in the breast care center, is a shared informatics structure among the network that allows for automated capture of patient-reported outcomes, and that's in the form of surveys and things like that. And it allows for tracking of symptoms over time, including pain, including swelling and those sorts of like medical things, but also including things like distress, anxiety, and also things like patients' diet and exercise. And the use of electronic questionnaires specifically allows us to not only automate the way that we collect this information, make it so that patients can complete this information from home, but also it allows us to have a lot of aggregate data that we can use to track longitudinally what's going on with our patients. And in the breast care center, what we do is when a patient schedules an appointment, the appointment information gets fed into our Athena platform, and what that does is it triggers a questionnaire to be emailed to patients to complete before their appointment. And once a patient completes that questionnaire, a questionnaire summary report is generated, scanned into the medical record so that clinicians can access it, and then clinicians can then take a look at it, see what's going on with their patients. At the same time, what we do is we generate referrals based on patients' question responses, and providers, if they see that, those referrals, they can sign off on the referrals and then send the patients to their respective clinics so that they can have consultations with these supportive care services that we provide. Here are some of the referrals that we make. You'll see that we make genetic counseling referrals based on personal health history, family history of breast cancer, and other personal history of diagnoses of cancer. We make psychological services referrals based on levels of distress, based on the NCC, based on a distress thermometer, and also based on the PROMIS measures that you've heard a little bit about today. We make social work referrals based on patients' expressed need for things like transportation help, assistance with insurance and all of those kinds of things. And then we make fertility and smoking cessation referrals as well, based on whether patients are interested in having children in the future, and also based on their current smoking habits. So I have 3 guiding questions for my presentation here. First, are patients who meet referral criteria for these services actually scheduling appointments? And if not, why are patients choosing not to schedule appointments? And then are there other supportive care services that patients are interested in that we're not currently providing? So the answer to the first question is not always, and you'll see that what we do with the Athena intake form, so we had 577 patients complete this intake form for over a 6-month period between November 2014 and May 2015, and of those, 74% agree to allow their data to be kept for research and also agree to be reached out to in the future to participate in research studies. And of those, you can see about 60% have a cancer diagnosis and 162 don't. It's like high-risk patients or patients who come in for an abnormal mammogram or something like that. This is a basic patient, the patient characteristics. We have most of our patients are between the ages of 40 and 60. Most of our patients are white, have graduated from college, and also have private insurance. And there's slight differences between our cancer and non-cancer patients. And what we see is our referrals, and I have an infographic here, a pictorial representation. So about 40% of our genetic counseling patients meet referral threshold. So if these 20 women here represent all of the women who received genetic counseling referral, about half of those have their referral signed off on by a provider, and about half of those actually result in appointments that are completed. And so you'll see out of 20 patients who are referred, only 5 end up consulting with genetic counselors. And you'll see similar trends with psychological services, social services, smoking cessation, and fertility preservation. And I have another slide here that shows, so all of the dark blue bars are patients who had met the referral criteria but then never had a referral signed. The light blue bars are patients who the respective services got a list of their names, but they decided not to complete an appointment, or they were not able to be contacted. And that like gray gold color is patients who actually completed an appointment. And so we see here that we're not totally matching the patients that meet the referral criteria to appointments. So my next question, why are patients choosing not to complete appointments with UCSF supportive care services? And primarily the reason is they don't think they need the services, actually. So what we did was we created a supportive care utilization research survey, and we sent, of those 428 patients in that 6-month period who completed the questionnaire, we sent out 423 emails inviting them to participate in research. And of those, 208, or about almost 50% of our patients completed the survey, and this is after 3 reminder emails and 2 reminder phone calls. It's hard work. And what we asked about is we asked about patients' interest in the supportive care services that we currently offer. We also asked about why patients didn't use the services. We also asked if they did use the services, we asked whether patients found them helpful. And the other thing we did was looked at what are patients' preferred methods for receiving information about the supportive care services that we offer. And here are some reasons for non-utilization for psychological services. Like I said, the biggest factors were they didn't think they needed the services, or they didn't think that they were contacted to schedule an appointment. And the things that were least important to patients were not having time or preferring other methods of care delivery. And with genetic counseling, you see a sort of similar profile. Most patients who answered our survey said that they didn't think they needed genetic counseling, and a subset of that also said that they had already been seen or tested and didn't feel like they needed that service anymore. Things that didn't end up being factors for most of our patients are people who were afraid of the results, there was too long of a wait, or that they didn't feel that they could afford the services. We also had space for qualitative responses, and here were some of the things. People who weren't UCSF patients didn't feel that they should get these services here. Patients felt that their doctors didn't recommend the services. Maybe they lived too far away. And what I thought was sort of interesting is social services reached out early in my diagnosis. In the midst of the turmoil and activities during that time, the value of this service is lost. And I think that is very key in thinking about and putting all of this in context is, what is the timeliness of the services we're delivering, and can we do a better job of that? So that's something, it's a little seed that planted in my head.
So what did she mean? That it wasn't helpful when we offered it, or?
Yeah. Mm-hmm.
Sort of just
yeah.
Maybe waiting.
Yeah. But of the patients who did complete appointments, they overwhelmingly felt that the appointments were helpful. And we also solicited feedback on how to improve our services that I can share with any of you if you're interested in taking a look at that. So the third question that I have here is, are there other supportive care services that patients are interested in? And the short answer is patients are very interested in these nutrition, exercise, and also integrative approaches to health. And what we see is that almost 30% of our respondents were interested in nutrition, about 26% interested in integrative medicine approaches, and 22.6% interested in exercise. And then the largest areas of, the smallest areas of interest were smoking cessation programs, fertility services, and also work after cancer treatment. Keep in mind that these patients who filled out this survey were by and large out of treatment at this point, or out of active treatment, so most of them are now maintaining on hormonal therapy. So then the other thing that we asked is, what were patients' preferred methods for receiving information specifically about exercise and nutrition counseling? And this chart shows that even though what we offer at most clinics in most centers across the U.S., in-person group classes, that was the least desired out of the offerings or out of the options that we had listed. Of course, with in-person individual sessions being the most desired. And so you can kind of see how that plays out here. And this gives us an idea for potential future directions for thinking about how we can implement supportive care services that meet our patients' needs and also desires. So future directions for this work, one of which is, so Dr. Molisco and I have been working to launch follow-up surveys for patients to complete at the end of active treatment. So that's at the end after surgery and also after chemotherapy and radiation. And what that would do is that would allow us to collect really long-term follow-up data on patients' symptoms, long-term follow-up data on things like fear of recurrence and things like that. The other thing that we could look at is exercise and nutrition referrals. We actually have exercise and nutrition resources available in our cancer center right now, so are there ways that we can better connect what our patients want with what we already offer here at our cancer center? And I have further analyses planned with the research or the data that I've collected, including looking at what patients' interests are versus whether that triggers what their stated interests are and whether that triggers a referral, whether levels of distress correlate with their self-reported interest in these services, and also whether the referral's triggered, or whether having a referral triggered matches the preferred formats for receiving information about supportive care services. So that's it. I have a big thank you to everybody I've worked with, everybody who's helped Athena get off the ground, especially my mentors, Dr. Melisko, Dr. Kaplan, Dr. Van Veer, who really helped guide and helm this project, and everybody who helped collect data and build surveys along the way. Thank you.
I think that the takeaway is the result of one set of intervention leads to many more interventions. So that's job security. It's not a bad thing. But I actually think that that is going to be the future of our work. Our work should be that we implement things, we get feedback on whether it works, we're tweaking it, we're improving it, and thinking about the next thing. That's actually the whole quality improvement mantra. That's actually, but there is no way to integrate that into medicine unless you have this kind of feedback. This is empowering, right? And did it depress you? When you were depressed when things weren't working, but didn't this work of finding out what worked and didn't work, was that disempowering or empowering?
It's very enlightening for what we can do and what we can do to make things better for our patients.
Yeah, so it's motivating.
Yeah.
If you can get feedback on what to do next. Laura, yes.
I just have one question, which is a piece of information you now also have, because you're in the midst of all those people you work with and in the midst of all those patients. I think there was like 500 in 6 months, right? So there are many. And so there's one point where all that information comes together about those referrals and then takes off in different directions. So, and you have played, I think, an instrumental role to make that part happen. So what do you think is the most, what would you recommend moving forward? How, where that nucleus point that sort of gets the information, sends it out, how in a clinic should that be implemented, fostered, being self-guided, or what do you think?
I think a big part of this comes back to this dream of one source and getting all of our information into the system.
That's the right answer. It's always the right answer. Okay, so.
But truly, a lot of what happens is we end up with patients who meet criteria for referrals, but then for one reason or another, their appointment gets rescheduled or something happens, and then those referrals just fall out of the system. And there's no real way other than human intervention to catch that. And that shouldn't happen. Patients' access to healthcare shouldn't be determined based on whether I check whether their appointment was canceled. And so I think one of the big things is figuring out how does all this information flow, and how do we collect all of it in a way that's actually usable, workable for everybody who's busy and has a million things to juggle, like our clinicians.
Maybe what I was pushing towards, like for in the screening part of Athena, we have somebody that's called a breast health specialist, where even the tasks are much less, or much less diverse, right? And so maybe there should be somebody that sort of hovers around all of this.
Yeah, like a navigator.
What is a navigator? Yeah, I think it's a workflow issue too, and I think this is also one of the things that I always think about. These are the criteria and the thresholds that we set, right? So we clearly don't have the right threshold for psycho-oncology, but I think we don't. I think, and maybe Jeff, you can think about this a little bit, but there should be, maybe a next level of, it's like misplaced precision. The next level might be, okay, we noticed on your survey, we just want to get some feedback, send something that automatically says, we noticed that you had some distress here and that you might have this. Are you interested in any of the following services? So, and it's funny that on Wisdom, we have now moved to you get a special viewing. Anyway, don't go. Okay, that that we actually moved the referral for prevention to only the top 2.5%, almost for this very reason. You get 5%, you get a lot more patients, but really, let's start with the people who for sure have a really good interest in that we could interest before we extend it further. This is our threshold, what we think people would want, but most people don't want it. So being more discreet, where you only intervene in that smaller group of people, but then maybe in that in that next layer down, just send a survey back. We notice you have these things. Are you interested in the following things? And maybe thinking about the timing, think about how we integrate into one source and say, okay, we just don't have the opportunity for workflow, but I think going forward, we probably do. And that this work is so critical for design, right? Right, for trying to figure out, mapping it out and figuring it out as a whole, how the whole system can work.
So I think patients should be more easily be able to find where this sits.
Yes.
Because for them it's sort of like
Yeah.
something in the background. that
Agree.
may get
Yeah.
to them, but they have no idea where it is.
I agree, and I'm sorry Michelle left, actually, because I know it's been super frustrating for her that all this stuff just can't happen, and why can't it happen? You know, it's because we haven't quite figured out how to get it right. And this is about how we set up an infrastructure and how to get it right, if we can get it so that we can, okay, now we've got our foot in the door, we keep making better and better and better every year with each one of these pieces. So thanks for all the foundation work and all the great grunt work. I know it's been, it's just like any one of you guys who's starting something new. It's a lot of hard work. When you get to take something that's already partway there, it's easier. But there's still a lot of hard work in making all this stuff better. T, did you have something you want to say?
Yeah, and I do want to respond to one of the notes that you said about we've noticed that you've experienced distress or anxiety in some of these areas. We do get the referrals from psycho-oncology about that distress and anxiety, and I'm able to do outreach, and I always refer patients to the Cancer Resource Center and see if they need additional support, such as patient support course. So that's something that we are trying to work on.
I think we need to figure out a better organized connection, especially since I think that part of my secret plan is to say that what people should be paid for going forward is filling out a checklist and having a patient centered consultation note. That is what should constitute a new patient visit. So how do we actually start to integrate the stuff that we're doing in one versus the other one? Sort of one is structured a different way. And one, you know, how can we do a better job of integrating this and thinking about this as part of our own source ecosystem? Okay, I hope everyone was stimulated, excited. I'm so proud of all you guys, really. It's an impressive body of work. It's amazing to see how everybody grows during the year. Even those who've spent a second year, how incredibly impressive it is, how much change there is even from the first year to the second year. You may not see it yourselves, but we see it. And for all you guys starting, this is your future. It's pretty exciting, don't you think? Yeah, so we're really looking forward to a fabulous year. As you know, because we're focusing this weekend on our intern reunion and sparking innovation in healthcare value. This is our first, hopefully not our last, but this is, you know, once you're part of the family, you're always part of the family. I think it's interesting that Dave Gellis, who's about 10 years out, is giving a talk Sunday morning about everything I learned in life. I learned at the BCC. So we'll take that as a compliment, and we look forward to seeing everybody this weekend. Get your minds going and get your creative juices on, and we'll see you all tomorrow morning. And to those of you who've been here, thank you so much, and some of you will see on the hike. So.